So we are back just in time for 460 adult services. This says Medicaid provides basic health insurance coverage for approximately 30,000 eligible adults. Wyoming Department of Health uses these funds to provide the basic health care services that are mandated under Social Security Act for all Medicaid beneficiaries. Medicaid, I believe that would come to you, sir. Go ahead, Jessica.
Chairman Pendergraph. So we offer a healthcare plan. Most adults on Medicaid, whether they're an adult through this program or through one of the home income-based waivers, offer the same adult benefit plan. The main thing that's different between our child benefit plan is that has less dental care. There's been some restrictions of dental and some other optional benefits. And also that acronym that you said earlier, EPSDT, or Early Periodic Screening, Detection, and Treatment, that applies to children, but does not apply to adults. So that basically says when we find something for children, we'll treat them for that. That same concept does not apply to adults. So for adults, if something is not covered, it is not covered. I'm open to any questions here, but this is just the primary healthcare plan for adults on the program. We do have a separate benefit plan for pregnant women. I will note that there is in the last few years, there's been a postpartum extension that the legislature pursued, which just took the after birth. So before we were covering 60 days after birth. Now we're covering 12 months after birth. And that allows full postpartum care to occur, counseling, treatment, any conditions resulting from pregnancy. And so I think at this point, maybe 40 plus states have adopted that postpartum extension. It's quite common.
Thank you. So looking at the numbers, there's been a shift. 2019, 2020 looked like general funds, federal funds were fairly close to each other, and then that has shifted. So what happened there, and what are the other funds involved?
Sure, I do. So in this unit, there is that primary benefit plan. And then we are also operating these hospital-based supplemental payment programs. So we have a number of those programs. There's a private hospital program and a public hospital or non-state government-owned hospital program. There's also a physician supplemental program for physicians that are attached to hospitals that are part of a hospital network. And then recently, in the last year or so, we've had the ground ambulance program that's been approved. And so those all, without state funds, without the state general funds, are allowing higher cost coverage, generally referencing Medicare rates to bring the cost coverage up higher than what we've been paying just through direct fee-for-service rates.
And Mr. Chairman, if I may add to that, this dovetails with a discussion we had this morning. So in addition to kind of your straight 50-50 split for services that are reimbursed half by the state, half by the federal government, our reimbursement rates that we pay, we often bring the legislature budget requests for rebasings, things like that over time that, the cost of service for delivery out by the providers has gone up or whatever the case may be. The federal government offers these supplemental payment programs, or what I referred to this morning as provider tax programs, where for certain types of providers, Jesse mentioned the ones that we have in Wyoming, we assess a fee to that group of providers. We collect that revenue, match it with federal funds, and then essentially redistribute it based on a formula back to providers. It's a federal allowance, federal program that you can do, generally up to what we call the upper payment limit, or what Medicare would have paid. And so the state, for as long as I've been here, has had those programs primarily with hospitals and nursing homes. But as Jesse mentioned, the legislature in the past couple of years added psychiatric residential treatment facilities, of which we have 2 in the state. You heard from one this morning, and a ground ambulance supplemental payment program. So Chairman Pendergraft, to your question, that's a lot of the reason for the increase in other funds here, which is booked in that sort of revenue and is not an exposure to the general fund.
Committee? Everybody happy? Anybody in the room? Comments? Anybody online, public comment? All right, let's move along. 463, nursing facility services.
Chairman Pendergraft, nursing facilities services pays for all the costs of people that are in a nursing facility plus the nursing facility costs. So hopefully this is clear. It's actually the population that's nursing facility residents. So this is their total medical cost, not just the nursing facility portion of that. And so what this budget unit does is it pays the nursing facilities directly on a per day basis. So every time somebody who's on Medicaid is in a nursing home, we pay them for every day that they're there. In addition to that, there is a supplemental payment program here that there's kind of layers of programs actually. So there's a broad statewide program that all the facilities participate in. And then on top of that, there is a non-state government owned, which we call the public, which brings them up to another, any remaining cost coverage after the first program, they can provide some funding and then claim the rest of that federal funding. So that generally brings them up to, I think at this point we're targeted at 90% cost coverage, but as costs keep increasing, that cost coverage slips, and that's where you'll over time see the department bring budget requests to say, hey, the cost coverage is starting to slip statewide, not on a specific facility basis. And we try to stay in between the 80% and 90% range so far. We have in previous legislatures have attempted to get to 100%, and it has stayed there for a year or two. And then they're like, how's it at 93% again? Well, costs went up. So, they have, that has happened pretty recently that, the legislature did target 100% cost coverage and had a quite large appropriation to meet that. But within a few years, it was back down in the 90% range.
Committee? At least you're consistent. Folks in the room? And anyone online? Might reiterate, if you're watching online and you didn't catch the first announcements, as we go through these unit numbers, if we come to one that you want to speak on, please raise your hand so that we can get you into the room. Moving on to Unit 464, Hospice.
So Unit 464 is a really interesting Wyoming program. Hospice is covered by most states nationwide within their Medicaid programs. But in Wyoming, the legislature has also created a program to pay for the room and board. So there's 2 portions of a hospice payment. There's the medical payment, and then there's the room and board payment. And in many cases, the room and board payment was too expensive for most people to actually access hospice at a standalone hospice facility. So really, if someone got hospice at a nursing home, Medicaid could pay the room and board for those people. Or if they got hospice at their home, obviously they didn't have a room and board payment, that was their house. So the legislature created this because there was really a gap of people on Medicaid being able to access hospice at the standalone hospice facilities that are in a couple communities. And so this made that a lot more accessible. And so essentially there's two payments that are occurring. There's the room and board payment from this fund, and then the regular hospice payment is occurring from the nursing home 463 budget. And so we get federal match on the regular medical hospice payment, and we reference by law, we have to pay Medicare rates for hospice. So we pay the same as Medicare. And then this budget comes in and pays the room and board on behalf of individuals who largely couldn't afford it otherwise.
So we see pretty consistent numbers from 2017 through 2024, and then it close to doubles for 25, 26. Why is that?
Are you referencing the trend document? So there was a change by the legislature, and I need to see if it's 424103A 25. But there was a change by the legislature to move from 50%. So there was, when this program was first created, the state was paying 50%, assuming that there was no federal funds available. So they were just paying 50% of the room and board cost, and the recipient was responsible for the other 50%. And then the legislature revisited that with legislation later. And I believe this has been in the last 3 or 4 years. To actually say no, not 50%, but 100% of that room and board cost. And so essentially, there hasn't been any more utilization of hospice. It's just that it's shifted to be 100% of that room and board cost, because I think there was, this was an interim topic for joint labor. And it was brought forward that basically people were not able to afford that 50%, because it was still a large dollar amount. It was like $50 to $60 a day. So the legislature made that change, and there was a bill. And so it basically changed the permanent standard appropriation to that number you're seeing. Generally, we consider hospice to be a relatively cost-effective service. It's just an alternative to other types of care like nursing home care, inpatient hospital care. So this, while it's a unique program, it does, I think, for people who prefer this type of care, it's a good option.
Committee? Anybody in the room? Yes, come on up. Please introduce yourself and tell us what we need to know.
Chairman, thank you. Chairman, thank you for giving me the opportunity to speak. My name is Kilty Brown. I'm the Executive Director of Central Wyoming Hospice and Transitions here in Casper. I just wanted to share some of the impact of hospice. So when you look at it, over 1,900 residents across our state receive hospice care, or actually they pass on hospice care every year. 41% of people over the age of 65 get hospice care. So this is like an important program for our community. I think it's really important to note, I just wanted to really impress on the fact that hospice saves the state money. There was a big study out of the University of Chicago that came out a couple of years ago that said that having hospice care saves taxpayers 3.1%. Rather than if they were not in hospice, because they would be going to the nursing home, sure, but they're also going to the ER all the time, and they're going to the hospital. And we provide 24-hour services. We're incredibly cost effective. We provide a lifeline in the middle of the night where we can care for people in their homes or in our hospice homes. There's only 5 hospice homes in the state of Wyoming. The problem is, if you were in Texas or Arizona or Florida, you'd have the population that'd be no problem keeping these homes open. But we struggle, and we really rely on community philanthropy to make sure that there is a home open for that rancher who lives out in Wright and who can't get a nurse real quick. Or sometimes you get a little old lady who doesn't have any family, but only has church family and who can come and take care of her in the middle of the night. And so that's what our hospice homes are for. I just really want to impress upon you guys the importance that we serve to this community as a safety net for the elderly and dying. And I want to thank you for the time you just gave me to share that.
Thank you for giving us that information. You mentioned a study in there. Is it possible that you could get us a copy of that?
Absolutely. It's a NORC, from the
Okay.
NORC out of University of Chicago, and I can send that to you later.
If you could forward that to the VLSO and they'll get it to us, I would appreciate it.
Okay.
Thank you.
Thank you.
Questions from anybody else? No. Anyone else in the room care to comment on the hospice? Anybody online? Nobody online. Unit number 470, optional services adult.
Chairman Pendergraft, so this covers the services that are considered to be optional under the federal definition for Medicaid. So and I think they also did a great job in the report that was reviewed describing those optional services. And so this is the optional services. And so, the biggest one in terms of cost is pharmacy. But most of us today would not consider pharmacy to be an optional benefit. So when we're saying optional, we're not saying not necessary. We're just referencing the federal definition and whether this is, could we cut it if the state chose it? Because the mandatory benefits may not be eliminated, if that makes sense. In many cases, the optional benefits are lower cost alternative to the mandatory benefit. So that's where we do have to be thoughtful about, is this optional benefit an add-on that's kind of a luxury, or is this optional benefit actually diverting from something that's higher cost? So I think a good example is durable medical equipment. You might have something that's home-based for durable medical equipment that allows you to not actually access the ER or outpatient care or inpatient care. And it's just helping you to stay at home. And, that piece of equipment could be $250 or something like that. But if it's helping you to stay in your home, it's a cost aversion. Pharmacy, similar idea. If you're a diabetic, insulin and those type of things, that's a covered benefit through this. So we just have to be thoughtful because sometimes it's kind of whack-a-mole that you could save on some of these optional benefits, but it actually shows up in a different benefit. Hearing aids are also considered to be an optional benefit, and audiologist services. But generally, those type of services help people avoid more expensive services long run in long-term care, home-based care, and then possibly nursing home care. So just to be thoughtful there, this shows the federal share and the state share. And this unit's a little bit odd. And you might say, hey, this is a 50-50. Why don't these match? We also get pharmacy rebate, which is very unique. And pharmacy rebate covers about 50% of the total cost of pharmacy. So we have, across all of our populations, about $80 million that's spent per year on pharmacy, including children. But the pharmacy rebate actually lowers that cost to be about half of that. And then we share that pharmacy rebate back with the federal government. So it's just a really unique feature of the Medicaid programs that's not common in private insurance, but we have these negotiated rebate agreements that are required by federal law.
Mr. Chairman,
Yes, sir.
If I might just add on the optional services, and again, LSO did a good job with your introductory memo. If you go back to our previous 2 or 3 rounds of budget reductions, both in 2016, 2017, and then again in 2020 to 21, you will see some optional services that were targeted there. So a reduction in adult dental services, a reduction in vision services for adults. So that, to Jesse's point, that is common to look at, where we are not required by the federal government to provide a service. And you'll see that kind of comporting with some of the information from previous rounds of budget reductions. But I think Jesse makes a great point that it's really necessary to be thoughtful there, because you could, Medicaid's an interesting beast where you often, it's like a balloon. You push on one side, it's going to come out on the other side. So if you reduce a benefit here, you might see an increase in, nursing home services or hospital inpatient or emergency departments. So we try to be thoughtful with that as well, but also prudent when state fiscal pressures, like what happened in those previous rounds of budget cuts, really did require us to make significant reductions, in addition to some of the across the board reimbursement rate reductions that you saw. There were some, in some cases, full-scale benefit eliminations on programs that are considered optional by the feds.
Thank you for that.
Chairman Pendergraph, I will note that there are 2 optional populations. One is the employed individuals with disabilities. So they pay a premium to participate in the program. That's up to 7% of their income. And so those are individuals that have a disability, and it's a verified disability, and are employed. And previous rounds of cuts had identified, these are an optional population. And then, over the course of multiple years, those actually were never implemented, both due to action by the legislature and by the governor at the time. Similar, we have a program called the Breast and Cervical Cancer Treatment Program. And so that program treats women that are under 250% of the poverty level that have breast and cervical cancer. And so that is an optional population. There had been previous efforts to look at the income limit of that 250% and change that. And essentially both of those optional population changes over time were abandoned, and neither were ever implemented. And we found savings in other ways to cover those cuts. Because those were quite difficult cuts to implement. And there wasn't a huge amount of people on those programs, but it did lead to very challenging discussions. And, essentially those were backed out over time and never were implemented.
Committee? In the room? And online? Okay, let's move on to 483, which is community choices.
Chairman Pendergraph, community choices waiver, and you might see this by other names like the long-term care waiver. That was the old name for this program. But the community choices waiver is for individuals that meet nursing home level of care. It's an option for those individuals to receive care in the community. So it's a home and queue-based services waiver. It's a 1915C waiver by our parlance. And what it does, it allows people to get personal care, emergency transponders, like if they're in a situation, they can have a call, home delivered meals. It covers the medical portion of assisted living facility care if people choose that option. That's a less common option, mainly because not many assisted living facilities accept Medicaid. Just even with our reimbursement, it's just not sufficient in many cases, because that person's remaining portion, that's their room and board payment, is still unaffordable for many people. But so this program offers, and is actually now much larger than our nursing home population, offers that home-based care to help avoid people going to the nursing home or to delay that. And it's been quite successful. So when we started this change, this became back to 2013 Medicaid reform. This program was capped and had a wait list essentially, and this program became uncapped. So basically, it serves everyone who qualifies. And since that time, we have seen our nursing home enrollment drop quite dramatically. So where before it was 40% maybe home-based and 60% nursing home-based, now it's 67, 68% home-based, 32% nursing home-based. And it's not just that the total number of people served has increased, it's actually that the raw number of people actually accessing nursing home care has actually dropped over time. So this has been successful at keeping people in their home. The director's office actually has done some studies on this to say within a margin of error of statistical significance that this was cost neutral to have this program versus the same amount of people going to nursing homes at the rate that they were going to.
So would it be fair to say then might be cost neutral, but I would imagine many of the people that are cared for are in much more comfortable at home rather than in a facility?
Mr. Chairman, you're right on the mark there. And this, I want to be clear in my comments that, over time, I think it can come off as, the Department of Health has a preference for, home-based care versus, nursing home care. Both are important parts of the continuum, and you need nursing facilities and long-term care facilities to fulfill needs when they can't be met in the home. But you're right. Generally speaking, there's kind of two things going on here. One, it's generally on a per member per month basis, more than half the cost of nursing home, and also generally the preference of our seniors to stay as long as they can in their home, again, assuming that it's safe. And I just want to reiterate something Jesse mentioned, that the eligibility criteria for this program, clinically speaking, are exactly the same as someone who would qualify for nursing home placement. So you have to meet that level of care that you would be clinically eligible and in need of that type of assistance. But it's an interesting question. It's both philosophical and economic that you guys in the legislature have posed to us over the years. Does this save money? And our answer is always frustrating that yes, it probably saves money, but it's hard to draw that line of causality when you have a program that's started and uncapped, how much demand was induced versus what it would have been. But the analysis does show somewhat clearly that we believe that at the very least it's likely cost neutral. That we've seen those nursing home enrollments go down over time, and this program have pretty significant enrollment that leads us to believe there's likely some offset of those institutional costs since the state legislature decided to direct us to implement the program.
What about provider staffing? Are there a lot of maybe, I don't know what you'd call them, freelance CNAs, or how are these staffed? And are you able to readily find those people?
Mr. Chairman, I'll let Jesse weigh in on that. It's always an ongoing challenge with, you have a program, you have a funding source behind it, but across your communities, how many providers are there? What's the capacity of different communities to deliver it? But Jesse, go ahead.
Chairman Pendergraph, so it really varies by service. So some services, home delivered meals, are pretty widely available. So the senior centers or Meals on Wheels. We also have mail order meals. So that service is pretty widely available. We have self-directed care where somebody can hire somebody they know, like from their church or from the community. And so that person doesn't have to set up all business. It's run a little bit more streamlined than that. And then some people need skilled nursing and things like that. And that can really vary throughout the state, whether that's home health and skilled nursing is available in every community. So it kind of varies around like what services people really are getting on this program. It serves mostly seniors, but it also serves disabled adults. So, somebody might be 40 years old, but need assistance with activities of daily living and might meet nursing home level care, they would also qualify for this program. So basically this starts, I believe, at age 18 and up. And just offers that extra care. Trying to see what other services we do here. We can do non-medical transportation. So that would be, a lot of senior centers do offer this, where, they go and pick someone up from their home and take them to the senior center, or they need to just have transportation to their medical appointments or something like that. So that's another service that's offered. That's something we're really focused on right now, is trying to improve that.
Senator Larson.
Thank you, Mr. Chairman. So I hear a lot of senior center comments here. So how do the senior centers go through this process? I guess I don't know if PAL's part of that, or if they just don't know that it's available.
Chairman Pendergraft, Senator Larson. So some senior centers are providers for this program. I wouldn't say they're the most common provider. So any senior center could enroll as a Medicaid provider and bill for the services it's providing. So some of them are doing home health, some of them are doing personal care. Some of the senior centers or other organizations in a similar community are doing like the housekeeping. So just kind of range of services. So, that is something we've been working on, is to make sure that the senior centers are enrolled and billing for what they can bill for, because it's a good funding source for them. And generally they're present in every community, or present in most communities. So that, they could be a good provider resource for us. Some senior centers are billing a lot of services. Other senior centers just haven't gotten there yet in terms of being able to bill. And that's something that, as we move forward, we're going to look at how to streamline some of those things.
And Mr. Chairman, if I may, to Senator Larson's question, there's nothing that requires any type of provider. There's nothing that requires any provider to enroll and accept Medicaid clients. And that holds true for senior centers as well. So it is a mixed bag. You have some senior centers around the state that really use both the aging division funding that we'll talk about later and Medicaid kind of concurrently, where folks who might not be on a Medicaid program but might be going in that direction, they'll use some of the Older Americans Act funding and our state funding and some of the programs to say, okay, we're going to provide this level of support now, and then as maybe a condition progresses or someone continues to age, and depending on their financial situation, perhaps we'll go the Medicaid route, the community choices waiver route. But that's not compelled by the state or by the legislature to compel any provider to enroll in Medicaid and deliver those services. To Jesse's point, it can be a benefit, but I think those local providers, in this case, we're talking about senior centers, not meaning to dime them out at all, but it really depends on the population they're serving, their business model, et cetera. And that's really the case across a lot of our Medicaid services, where whether it's a company or a nonprofit or a county function, to do that calculation and determine if it makes sense for them.
Okay, so let's say a senior citizen, the center decides that they want to take advantage of this and they want to be able to bill Medicaid. Are they then, or have they already been for other reasons, subject to health department surveys? And is the cost both to the health department and those facilities figured into any of this?
Mr. Chairman, if I understand your question correctly, so there's obviously a process to become a Medicaid provider and to enroll as a Medicaid provider. Certainly let Jesse elaborate on this. We've streamlined a lot of those processes with our new systems that we were talking about this morning, where it's relatively speaking much easier to enroll in as a Medicaid provider now. And as we mentioned before, our provider enrollment system is very quick. Our payment system is very quick, et cetera. So I think a lot of that's easier, but in this particular case, there wouldn't really be, an OHL, an Office of Healthcare Licensing and Survey component, as a non, facility-based care that's per state statutes, one of the healthcare facilities that we'd be licensed and licensing and regulating. But there are regulatory components through CMS if you're a home health provider or a home and community-based provider, absolutely, to be clear. But it's a little bit different than saying, hey, we're a facility that's already been certified and surveyed and operate, and so why not just bill Medicare or Medicaid? This is a little bit different when you're talking about a community organization like a senior center.
Chairman Pendergraph, I don't think it would be a big barrier, but there is certification. So most of the services that you'll see in this community choices waiver and other waivers are not licensed. They're not licenses under like a Wyoming board, like nursing or physician. So what the department does is we offer certification of those providers to just mean that they've completed the training and they meet all the requirements of that, but they're not licensed. They just are basically meeting the standards for that service. And it, in some cases, pretty minimal level of training, CPR in some cases, depending on the type of service, but not really verifying education for most services, not verifying medical training. It's completion of some training. And then in some cases, there's other levels of things, but case managers have probably the highest level of standards, so they have a level of education and training where you might, a homemaker or something like that would have much lesser, mostly than just criminal background check.
Well, thanks for that. I just wanted to make sure there aren't some hidden costs in there where, we think we're saving it here, but we haven't taken into consideration all of the additional headache, I guess you could call it. Any other questions, committee? Any comments or questions from anyone in the room? Would acknowledge former Representative Sweeney has joined us. Welcome, sir. Anybody online? Okay. Excellent. Mr. Burkett, welcome back. Maybe not.
Mr. Burke, it looked like you had your hand raised and we've unmuted you if you would like to go ahead and provide some public comment.
All right. Anybody else out there? You don't want to lose him if we can get him, but we also need to keep going. So.
Mr. Burkett, I believe you've been given permission to speak. If you would like to provide public testimony, I believe this is your last opportunity for this item.
All right, let's move on. Yep. We are on 485 comprehensive waivers.
And Mr. Chairman, if I can ask maybe for a liberty, if we could discuss the next two units together, the comprehensive and supports waiver. Obviously, Mr. Chairman, your broader committee at Joint Appropriations has dedicated a lot of committee time this interim to this topic. But I think for obviously the benefit of the audience here and the public, we'll discuss both. But I'll ask Jesse to, kind of consolidate his comments among these two waiver programs that really work. It's the same waiver, but two different mechanisms and work hand in hand together.
Chairman Pendergraph, so the comprehensive and support waivers work kind of together. to serve individuals with intellectual disabilities or acquired brain injuries. Going back, we used to have an adult waiver, a child waiver, and an acquired brain injury waiver. Through Medicaid reform, the model was moved to a comprehensive waiver, which provides primarily the difference is residential care is available on the comprehensive waiver, and the support waiver does not have the same type of residential care. Otherwise, they're very similar. They're providing services. The comprehensive waiver has different levels or acuity levels that people go through a screening, and then they are assigned a level of care, and they have a personal budget, where individuals on the support waiver have basically a max budget. So they are just given an allocation essentially up to like $25,000. It's not exactly that number, but then they have that budget to kind of allocate as they need. And then it's not use it or lose it. So that was one thing through Medicaid reform that was noted a lot of times, like, hey, I get to the end of the budget period and I need to spend all my money so I don't lose my budget. And people were spending $5,000, $10,000 on things they didn't necessarily want or need, so they wouldn't lose their money for when they did need it. So the model has, on both of these waivers, has moved away from use it or lose it. And that has actually helped a lot. Strangely, it's kind of counterintuitive that people are using less services because they're not afraid of losing them. People are just much more comfortable now to say, hey, if I don't use it, I'm not going to lose it. So they don't use services that they don't really need or want, just because they think they might need them in the next year. So these programs are home-based or at a home setting that a provider runs, and they help people avoid institutional care.
Did you want to add something? Okay. I would ask that you guys elaborate just a little bit on the two issues that we discussed back in August. One was the wait list. It would be an update for those of us on appropriations and basically an introduction to those who are just tuning in. So the wait list and then provider compensation, which were kind of the two issues that got this whole thing started.
Mr. Chairman, happy to do that. So, we have several thousand people on these programs, and as Jesse mentioned before, there's a wait list for these services. This is not a program that the legislature has uncapped that wait list, and so over time, the legislature has made a decision in the wait list for this program. Depending on the budget session, we're going to fund this many people off the wait list. So we historically have brought those numbers to the JAC, to the legislature periodically to say this is how many people are on the wait list, and this is what it would take to fully fund it, to partially fund it, half, a quarter, et cetera. And that was the first element that both in Gillette and in Du Bois at the Joint Appropriations Committee meeting, we were presenting numbers on to you all. We project by the start of the next biennium. So if we fast forward and do some estimates for next July, all things equal right now, we would probably have over 420 people on this wait list for the developmental disability waivers. And so we've provided options to the JAC at your request of, what's that funding to get the entire wait list onto the supports waiver, to do half. There's options there that the legislature can consider in the upcoming session. And that's the first element, which is we have folks, often, individuals themselves or family members with children who are on these wait lists. And right now, our average wait time, I believe, is around 14 months waiting for a slot to open up for funding. Previously, several years ago, we were well over 18 months and really approaching 2 years of wait time. And so, as I know Representative Sherwood will remember, we had legislative action, Joint Appropriations Committee action to fund half of that wait list and really target to get below 18 months of waiting period. And another way to phrase that is to take the folks who have been waiting 18 months or more and prioritize that funding. So that happened several years ago. And it's just one of those ebb and flow things, because as the demand comes in, you could fund the entire wait list right now. And then over time, month after month, year after year, that's going to build again, just based on the limitation that really governs what we can do is the overall budget. Secondly, in this system, you have providers, and we have methodologies for reimbursing those providers through the budgets that are allocated to these clients. And so those two things work hand in hand, funding people onto services and then ensuring that our reimbursement system is sufficient enough to sustain the provider network. And within that provider network, you have hundreds of providers around the state, and they vary from a small amount of larger, or what have sometimes been referred to as agency providers, so a bit more infrastructure, especially as Jesse mentioned, with residential services, things like that. And then you have very small provider organizations, in some cases family members of clients that are actually enrolled providers and delivering those services to their family member as a provider. And so those, the reimbursement rate discussion is absolutely crucial in looking at the overall DD waiver system. But we've tried to bring over the years that sort of combined approach to say, if we are looking at funding both in terms of rate rebasing, which we do per statute periodically, do a rate rebasing study on those reimbursement rates. We've always liked to bring both in tandem to the legislature to say, in addition to provider rates and reimbursements, how many people do we have waiting? And that's, these are challenging circumstances that families find themselves in. And so we believe that in presenting the legislature options, we should bring both of those concepts to the table, noting that whatever the Department of Health's budget request in those two domains might be in any given year, that the legislature always has options depending on the pressing needs and the state revenue situations. And those are always tough discussions to have, especially in a budget like the Department of Health, where we have so many, safety net critical type services and populations that you all have to weigh. So Chairman Pendergraft, I think going into this upcoming budget hearing in December and certainly into the next session, we will have robust discussions around, Department of Health budget requests. I know you've heard from the provider community and members, of the public who have, individuals and their family on these programs. So it'll certainly be discussed going into setting the budget for the next biennium, but more than happy to answer any questions.
Committee. Not very inquisitive today. Anybody? Yes, come on ahead. Please introduce yourself. Tell us what we need to know.
Just got to have the right touch. Chairman Pendergraft, members of the committee, thank you for letting me speak today. I spoke to you in Du Bois, but I'll reintroduce myself. My name is Tina Conley, and I am the director of iReach 2 here in Casper. When I spoke to you in August, I talked to you really with my provider association hat on to talk about the regulatory environment that we live and breathe. Today, I want to talk to you with my executive director hat on and tell you that I personally believe our system is pretty fragile. So we just took a 5% budget cut, give or take, September 1. I bill Medicaid about $1.6 million a year. 4% of that $1.6 million I'm already providing in free services to people. So then you add on a 5% reduction in reimbursement rates. That pushes it to 9%. And my company hasn't operated at more than a 3% margin to the good for several years. So that leads me to hustle up more grants, more fundraising, more this. But you'll never believe what I'm hearing from some of our funders out there. Tina, you rely too much on Medicaid. You got to create some other revenue streams before we're going to fund you. We're going to give you any grant money. What a predicament that puts me in as a director. So I'm just encouraging you to continue to look at both topics, the waiting list and that cost study that you have available to you. And my provider colleagues and I stand ready to help support in any way we can. Thank you for your time.
Questions, comments?
Yeah.
Senator?
Mr. Chairman, thank you. You mentioned a 5% cut. Can you explain that? I'm
That was
lost.
the rate reductions that went into effect September 1. There was a bill in appropriations on the legislative side to add to the budget this 3.86 million that went away when the ARPA money sunsetted. The Department of Health was able to continue that through September, but you know, they don't have just money growing out back in Stefan's yard. So, you know, we had to take that cut because when the Senate last year didn't pass the budget, then our appropriation also went right along with that. So that's where it's come from. And so that's the cut that we took September 1.
Mr. Chairman, if I can add to that, thank you, Tina. Well said. Senator Larson, so as you might recall, both in JAC and on both floors last session, there was a discussion around some expiring funding that had been supported by the American Rescue Plan Act, or ARPA. And both chambers discussed putting that back into the budget, and I think both successfully did. And then ultimately, with the failure of the budget in the legislature, we did not, have that direction to move forward. However, as Tina mentioned, we did look at what we could support temporarily to have a bridge into the next session, and kept some of those rate structures going. But effective this fall, had to make some tough decisions on what we could and could not keep going, given the where our financial projections for the Department of Health were going into the remaining 6 months of this biennium. So again, as I mentioned before, going into December budget hearings and the legislative session, you will see and can ask for information for the Department of Health on, what we will be requesting, what the governor might recommend or alter. But ultimately, that will have to be discussed legislatively on how we're directed to move forward with those appropriations. Senator Larson, I don't know if that helps, but that was kind of the genesis of those expiring rates. It wasn't a directed budget cut by the legislature, but something we had noted to you all that was expiring at the federal level, that was discussed in both chambers to potentially restore.
I just want to, follow up. Go ahead.
Thank you, Mr. Chairman. So I would ask, have you looked into a B11's movement of some sort to try to remedy this issue?
Mr. Chairman, thank you. Senator Larson, yes and no. And let me, not trying to be irritating with that answer, but over the years, we benefited greatly in the Department of Health from what I would call, number one, some prudent fiscal management of our budget. And also during several years of enhanced federal match rates, we locked down state general fund savings as opposed to spending it elsewhere in our budget, so that we could partner with the legislature on the deployment of what we call Department of Health reversions. We projected we were going to save X amount of general fund. And in fact, in the two previous biennia, it was $100 million of savings each biennium that we were able to realize. The legislature then, as you guys like to do, got excited and said, how could we deploy those funds for either budget requests that are being made and say, hey, we're going to fund this one time with your reversions. That happened quite a bit. In addition to 3 or 4 years ago, the legislature saying, instead of making those step 3 budget reductions in a few cases, use your Department of Health savings on a one-time basis and fund those items. And I think that was a great partnership between the department and the JAC and the legislature to make good use of those savings. We're in a different biennium. We're more razor thin on our budget projections this year, where we don't have as much potential general fund offsets, primarily because the legislature deployed a lot of those offsets in expenditure areas for different items that came up over the past 4 years. So we did what we could after the budget failed this previous session to keep those rates going as much as we could through this remaining fiscal year. But ultimately, can't keep squeezing blood out of a turnip, especially at that scale when you're talking millions of dollars. And I would just make another mention of one of our big challenges in that we talked about this morning with our facilities is we are spending a lot of money on contract labor to keep those beds open for those stakeholders. And so in any other scenario, could we have found offsets to fund some of these priorities or expiring funds? Potentially, but just wasn't the case financially this year.
Thank you. Any other questions, committee? Anyone in the room? Comments? Thank you, ma'am. And got somebody online? We had Jeff Gardner.
Mr. Gardner, you've been admitted to the meeting, so if you want to unmute and undo your video, you're welcome to at this time.
Yeah, thank you. Thank you. Can you hear me, Mr. Chairman?
Welcome, Mr. Gardner. We can hear you fine, and now we can see you.
Very good. Thank you. Mr. Chairman, I appreciate the opportunity to provide some comment remotely. This is a great option that the legislature has adopted. And I don't want to repeat anything that Tina said, the great things that she said. I just wanted, I guess, to, at the risk of being redundant, we've been having conversations throughout the interim on this subject. And, the fact that the last cost study was completed just right at a year ago right now, looking at the cost of providing these really, really important services. So there's an understanding too that there's not endless money, but the fact that we're talking about supporting some of the state's most vulnerable people with direct support professionals who work really, really hard to provide that health and safety and happiness are not at this point adequately compensated. So again, I don't want to be redundant. I just wanted to say, and I guess remind the subcommittee that there's a great tool right in front of us with the cost study, shows the cost of providing those services and the associated rates with them. And appreciate so much the time and effort that you've taken in this interim to look at this topic, and hope that we can continue that conversation in Cheyenne at the end of October. I stand for any questions.
Thank you, Mr. Gardner. It's good to see you again. Committee, any questions? All right. Thank you for your testimony.
Thank you.
So, Mr. Burkett, is he actually there, or do we just have a phantom residual?
Hello, can anybody hear me?
We can hear you now.
All right, that sounds good. I don't know what it was for technology issue and stuff like that, but I thought it was very important for me to be here today at this subcommittee because the reason why I wanted to talk to you about was I was born with a person with a disability, and I've grown up around learning how to navigate the world in a unique way that not many people would. And I've grown up my whole life just knowing about how much families are struggling to get by on healthcare premiums and just to afford basic healthcare. We see young people move in and out of the state because there's just so few options to seek healthcare and to get an affordable job. And which is why I was concerned about learning about these cuts that might take an effect, or just see about learning how these might take effect, and which is why this budget session is going to be so important, I guess you can say. What and how I've how the one question I've got today is just with the community choices waiver, just about the reduction of like the rate, about how would that affect persons with disabilities, how it affect the case managers to affect the clients, I guess you can say. Medicaid expansion, this has come up over time and time again over the last decade. But we have yet to see it pass, whereas many of our surrounding states have, and it's helped increase our jobs. It's helped increase durability, and it's increased healthcare, more affordable drugs, and more prices that people can afford. With I'm going back to a point I read earlier about the hospitals going back. It could affect many rural hospitals in the state, including the points I made earlier in Wheatland, as well as a hospital in Casper, as well as the Lovell and Powell. I don't know if I keep messing that up or not, but that's where I am. And just I'm concerned just about both the federal level as well as the state level, that increasing Medicaid or expanding Medicaid would also help with working families a lot. And the last few years, I have seen very little evidence where people like me, I mean, I wouldn't say we got hurt, but we're not keeping up with the rest of the people. That's where I'm going along with that. Right now, I'm a contractor for Aligned Services, where we help out with people with disabilities, and where we rely heavily on the community choice waiver. And I hear from client after client, from patient after patient, and from parent after parent about how this would be devastating, which is why the budget session is so important, and why I'm very strongly considering that you put a rate where you increase the rate for case managers, so that clients can continue to keep getting the support that they need. The community choice waiver has helped me out a lot with my CNAs, and also with trying to get along in the community. And I know well that it's helped out with a lot of other people too.
Okay, Mr. Burke, I do thank you for your comments. I'm going to step in there because we do have a lot of things to get through. I hear what you're saying about the waivers, and I would remind you that the reason we're here is because the people sitting on this committee were committed to trying to find a way to adequately fund those waivers. We think those are important things. And we take a step back and we say, this is a $2.3 billion budget. We would need to take a good look at it and see what we can find there. Maybe there's some way that we can move some money around and be more efficient. We don't know until we look. So that's what we're doing. But I also, as I started out at the very beginning of the meeting, and I'll just reiterate that, this state is headed toward a fiscal cliff. There is no more money. And we on this committee especially are acutely aware of any decisions or any recommendations. Actually, we can only make recommendations on the subcommittee, are going to affect people's lives. They're going to affect their welfare. And we take that very seriously. So we have to weigh all of these things. We hear about a person in this situation and they have a particular need, and someone else in another situation, they have a particular need. And it's very, very difficult to try to weigh all of those along with the goods of the state. So I'm going to go ahead and cut you off. And I hate to do that, but we do have others that need to comment. I just want you to understand that we are trying to be as compassionate as we can. Nobody wants to say no. We'd like to say yes to everything, but we have limited funds. And so we have to decide how to best use them. And I thank you for your interest and for tuning in. And is there anybody else online waiting for comment? Okay, with that, we will move on.
Mr.
502, which is public health preparedness.
Mr. Chairman, we did complete the gorilla in the room, which was healthcare financing and Medicaid. So moving on to the next section of the agenda, we have the Public Health Division, and our Senior Administrator of the Public Health Division, Stephanie Sandoval, should be online to help me give some overviews of these units, but we'll try to keep it to the same format, Mr. Chairman, if that's okay with you, how we went over Director's Office and our facilities with Public Health. But please feel free to pepper us with questions. I'll hand Unit 502, Public Health Preparedness, over to Ms. Sandoval. Stephanie, if you'd introduce yourself and take the floor, please.
Good
Welcome,
afternoon.
ma'am.
Good afternoon,
Welcome,
Mr.
Ms.
Chairman.
Bitsy.
Can you hear me?
Yes, we do hear you. Please proceed.
Great. So my name is Stephanie Sandoval, and I oversee the Public Health Division in the Wyoming Department of Health. As you heard earlier from our director, our division is comprised of 3 sections: the Health Readiness and Response section, the Community Health section, and the Public Health Sciences section. I'll go ahead and dive right into Unit 502. This is our Public Health Preparedness and Response unit. This unit is 100% federally funded, and funding in this unit supports our state preparedness staff, and is also, the funding in this unit is also distributed to your local communities and the 2 tribal entities to help prepare and respond to public health emergencies. This program also maintains plans to respond to a variety of potential emergencies, ensuring our state and local communities are prepared to respond to any incidents that may come our way. And I'll go ahead and pause in case there are any questions.
Committee, questions? Please proceed.
All right. Unit 503 is our Office of Emergency Medical Services. This unit works on licensing for emergency medical service providers around the state and also provides ongoing education for EMS providers. The unit also supports ambulance providers with regular ambulance inspections and technical assistance that EMS providers may need. The office also fields complaints related to EMS providers, and our trauma program is also seated in this unit. They conduct trauma designation site surveys at hospitals on a regular basis and provide technical assistance to hospitals when needed. Finally, our healthcare preparedness program is in this unit. This program supports preparedness efforts in our healthcare system. I'll pause for questions.
Okay, yeah. Committee, questions? Nothing to add from you folks? Okay. Please proceed.
All right. Unit 510 is our Office of Rural and Frontier Health. This unit has a number of programs that help our rural and frontier communities, starting with the Community Services Block Grant. That grant is housed in this unit. This funding is distributed to entities in your communities to help address issues related to poverty. This unit also works with hospitals on quality improvement efforts, workforce development, and recruitment and retention efforts. Our loan repayment program is also housed in this area. It does operate on a reduced budget due to budget reductions over time, and this unit also works to support telehealth efforts across the state. And I'll pause for questions.
Committee? No questions. You must be doing a terrific job.
Thank you.
Please proceed.
All right. Unit 522 is our immunization unit. This unit is funded through a combination of state and federal funds and promotes childhood and adult immunizations by providing education to healthcare providers and the public, reports immunization coverage rates, and oversees the immunizations for children attending schools and childcare facilities. The unit also manages the Wyoming Immunization Registry, or WIRE, which helps individuals and healthcare providers easily track their immunization records and helps folks to stay on schedule with vaccines that are needed based on their age. I'll pause for questions.
I do have a question there, and it's similar to a question that was asked earlier. Perhaps you heard it. We have a lot of different immunizations. When I was a kid, you were immunized like MMR and polio, and that was pretty much it. And now there's a long list. Is there a formal list of from where we seek guidance? How do you make your decisions as to what are appropriate and what are not necessarily appropriate vaccinations?
Sure. Thank you for that question, Mr. Chairman. So we do have a list that's readily available on our website, and I'm happy to share that information with the committee to cover the immunizations that are required for school-age children as they are entering school. And these decisions are really made based on, as the director pointed out earlier, our state health officer, CDC recommendations, and really the vaccine preventable diseases that could cause the most disruption or harm to the public. And so our information is available online if you'd like those specific requirements, or I'm happy to read them off if you'd like.
I think it would be good just to cite the website for us. I'm more interested in who makes the decisions about what is appropriate than necessarily what decisions they've made, at least at this point.
And Mr. Chairman, if I can jump in, so I want to clarify one thing, that we don't have required immunizations for adults. This is really kind of a requirement the state has had for many, many years for school-age children entering public school or childcare facilities. So Stephanie, you might speak to the legal requirements there, in addition to the list that's currently required for school-age children.
Certainly, thank you for that. So, Mr. Chairman, we do follow CDC recommendations. We know that process involves a lot of behind-the-scenes considerations, including the FDA requirements, FDA labeling. Then we look at the ACIP recommendations. Those recommendations are then finalized by the CDC director. So that's the typical process that vaccines follow. And then in statute, we do have the mandatory vaccinations that are required for school-age children. And as the director said, we don't have required vaccines for adults.
So, Mr. Chairman, if I can just weigh in there again, it really does vary by state. We try to balance those federal or national sources that are making their recommendations, and a lot of those we follow. But for example, during the pandemic, there were some states that started to require COVID-19 vaccines for children or adults. We did not follow that path. So we do, retain that discretion and flexibility as a state to, not to make our own decisions. But I think it's important that regardless of the administration, we know that federal entities like the CDC, the subset of that, which is Stephanie mentioned, the ACIP that reviews vaccine data, makes recommendations, and that changes over time. We take all of those into considerations. Generally speaking, we have followed CDC guidance over the years, but again, have not always made the same decisions that other states have when it comes to our child and adolescent population. And then again, just want to reiterate that the Department of Health does not have any required immunizations for adults.
Thank you for that. Kind of a follow-up question to that. You mentioned public education regarding immunizations. Can you describe how that is accomplished and the programs that do that?
Mr. Chairman, I'll start and then hand it over to Stephanie. So generally speaking, when a budget or federal grant funding allows, and it's not always the case every year, we will promote certain things that we think are necessary to protect public health. For example, when you get into the later summer months and entering fall, we know that it's easy to forget before you enroll a child in school, for example, the school is going to ask you for these either demonstration of required immunizations or to fill out an exemption form. And so we'll often, promote vaccine awareness during those types of time periods, just administratively to remind folks about immunizations that are available and that we would recommend, both in terms of school attendance, but also just to protect public health, whether it's, measles, rubella, or varicella, chickenpox, et cetera. So it does vary. It's not something that we have a set schedule for when we do public awareness or public promotion, but something we do as we believe is necessary and when we have available funding. Stephanie, please feel free to add anything I missed.
Mr. Chairman, the only other thing I would add is that our unit does work closely with healthcare providers, school nurses, really to provide that guidance and any, assistance that they may need.
Senator Larson.
Mr. Chairman, thank you. So quite a few times you mentioned we as making decisions, I guess, on immunization, maybe requirements or whatsoever. So who is the we? Is that the legislature, the executive branch, or the agency, or doctors?
Thank you, Mr. Chairman and Senator Larson for that question. In these comments, when I say we, I'm referring to the Department of Health. So both myself, Ms. Sandoval, Dr. Harris, but as Stephanie mentioned, we consult regularly with healthcare providers and also, our educational institutions, our schools, superintendents, school nurses, et cetera.
Any further questions on, what are we on? Oh, 522. Any further questions from the committee? Any comments from anyone in the room? Comments online? We are free to proceed to 523.
All right, Mr. Chairman, thank you. Unit 523 is our Maternal and Child Services Unit. This unit is funded through a combination of state and federal funds, as well as fees received through our newborn screening program. The unit works on issues related to preventing maternal mortality, preventing infant mortality, and promoting health and safety for children, also preventing adolescent suicide and promoting adolescent motor vehicle safety. Every 5 years, this unit conducts an in-depth needs assessment to determine the appropriate priorities for the upcoming 5-year federal grant cycle. And happy to take any questions on that unit.
Committee? Seeing none, please proceed.
All right, Unit 524 is our Nurse Home Visitation Unit. This unit receives temporary assistance for needy families, or TANF funding, from the Department of Family Services. And our Nurse Home Visiting Program is our hand-in-hand program that is offered in all 23 counties. And that program provides prenatal, postnatal, and infant home visitation services to improve pregnancy outcomes and foster healthy beginnings for infants and toddlers. And I'll pause for questions.
No questions. Thank you.
All right, Unit 525 is our Women, Infants, and Children unit. You've heard a little bit about this program today, but our WIC program is a federal nutrition program for women, infants, and children that focuses on the link between good nutrition and good health. The program serves low-income women and families who are at or below 185% of the federal poverty level. This program also helps new moms with breastfeeding support. And I'll pause for questions.
Seeing none, please proceed.
All right. Unit 526 is our Public Health Nursing Unit. The Public Health Nursing Unit offers services in partnership with local counties. You did hear a little bit about this earlier today. Our public health nurses are what we like to call our boots on the ground, who essentially carry out all of our programmatic areas at the local level. These services can include a wide range of services, such as our nurse home visitation program that I just mentioned, communicable disease prevention, testing and treatment, immunizations, Ryan White case management, chronic disease prevention, and assessments for Medicaid long-term care services. And I'll pause for questions.
Yay, we have a question.
Yay. Could you please enlighten me? What is the Ryan White case management? Thank you.
Mr. Chairman, Representative Sherwood, our Ryan White case management is for those living with HIV or AIDS. It provides services to them in terms of accessing affordable care and any other disease management that they may need.
Thank you. Any other questions? Seeing none, free to proceed. Thank you.
All right. Unit 531 is our Cancer and Chronic Disease Prevention Unit. This unit works to reduce the impact of the burden of cancer on Wyoming residents through awareness and promotion of cancer screenings. The Cancer Services Program reimburses participating providers for cancer screening and diagnostic services. This includes mammograms, Pap tests, stool tests, and colonoscopies. And I'll pause for questions.
There are none.
All right,
Okay.
Unit 532 is our public health lab. You heard a little bit about this area as well. Our public health lab provides chemical testing in the areas of alcohol and drug testing services to government agencies. It manages the state's breath alcohol testing system and also includes training and certification of operations and equipment for law enforcement. Our microbiology testing unit tests for infectious disease and provides advice to medical facilities, government agencies, and some water testing services. And then our preparedness lab, we maintain this capability to quickly respond to biological, chemical, and radiological threats. And you heard a little bit about this. So an example of this would be when we have a white powder incident in a community, our lab is equipped to quickly test that upon receiving it from law enforcement to determine if there's a threat with that. And I'll pause for questions.
I would just ask, say in the case of a train derailment, do you have the capacity to move around the state quickly to make an assessment, or are there other means for being able to determine what threats there are there?
So I would say with regard to something like a train derailment, we would probably look at a couple different areas of our division. First and foremost, though, any incident like that would be handled at the local level. If that local entity is overwhelmed and they need to reach out for assistance, they would contact the Office of Homeland Security, who would in turn contact us. And then we would be on standby. Then going back to that preparedness unit I talked about earlier, we would look at that unit to help see what that local community needed. And then we would make our services available on an as-needed basis, depending on what that issue was. To go to your question about the lab services, we don't have mobile services, but anything that would need to be tested could be quickly taken to our lab. We have a courier service that we can use, or in the event of something urgent, our law enforcement partners would get that specimen to us for testing. So that covers kind of a couple of different areas, but I think to go back to the initial response, that goes to local partners to handle that until they are overwhelmed. Then we and Homeland Security would step in to assist.
And Mr. Chairman,
Thank you.
if I
Go
may
ahead.
just give an example, this was a year or two ago. You might remember there's a tornado that struck, a rural area, but basically right in the middle of a mining operation. And I was out in Evanston at the time, but the team with our preparedness folks in conjunction with Homeland Security, we were through what's beautiful these days is we can get online through technology very quickly on a video meeting to assess situations without having to, send a team in a car when maybe assistance isn't necessary or required. So that team mobilized very quickly and was coordinating with Office of Homeland Security, Governor's Office, and the local emergency response entities to determine what services are needed, either in the healthcare realm or in other emergency preparedness realms. So that's generally how it works. Is once we're notified, we have essentially a few folks that can be on standby pretty quickly, and if we need to deploy, we on the healthcare side or the public health side, we can.
Thank you. I find that interesting. I probably watched too many disaster movies in years past. I want to take a moment and recognize Representative Ken Clouston. Welcome. Thanks for joining us. I believe that we're free to proceed.
All right. Thank you, Mr. Chairman. Unit 534. This is our communicable disease unit. This unit works on prevention, control, and investigation of communicable diseases in Wyoming. The program provides education, testing, and targeted interventions to individuals, community organizations, and healthcare providers related to sexually transmitted infections. And I'll pause for questions.
Seeing none.
All right, Unit 538 is our chronic disease epidemiology and surveillance. This primary funding, or the funding in this unit primarily supports the administration of our behavior risk factor surveillance system survey. This is a survey of adults in Wyoming to learn about behaviors that contribute to the occurrence of prevention of chronic diseases, injuries, and other causes of premature mortality and morbidity in the adult population of Wyoming. This survey helps inform efforts that we have in other parts of our division around prevention. And I'll pause for questions.
Just curious, I go back to another document, the strategic plan update, and it talks about the mission of the Wyoming Department of Health, and it says to promote, protect, and enhance. Under promote, encourage healthy behaviors, develop healthier communities. I guess part of the question, again, is who decides what's healthy? What are the criteria for that? And then how does that educational process go forward? How do you get the word out in order to, you talked about risky behaviors, other sorts of things. So you first, sir.
Mr. Chairman, thank you for that question. I decide and there's no debate. No, obviously that would not be wise. So when it comes to areas that broad, I think it's really a mixed bag on how through various functions or units of the department we set those priorities. I'll let Stephanie speak in more detail to this, but through our population health and these prevention programs that we're talking about, it's not a unilateral decision on deciding what to prioritize. And in fact, through our prevention work that happens, it's mostly driven by local prioritization, local needs assessments, whether we're talking about substance use or suicide prevention, or in this case, chronic disease. We want that to be bottom up, where communities, whether it's with our funding support or not, to determine what's best for them. However, on the other side of that coin, we do have a Department of Health, and I think it's important for us through the strategic plan and through what you can see perhaps in subsequent meetings, looking at our performance management data through what we call our health stat program, of how we select the most important outcomes within these programs or units, and frankly, how we're doing on achieving those outcomes. And that's also a mixed bag. We have some trends that are not as impressive as others that really are, where the state's made a lot of progress. But it really is, especially in the public health division, a lot of stakeholder engagement where we're not making unilateral decisions, but specific to healthy communities and chronic disease and this sort of make America or make Wyoming healthy again movement that we're in now. I'll certainly let Stephanie speak to how that is informing their division's strategic priorities and how the programs are making those decisions. Stephanie?
Mr.
Ms.
Chairman,
Sandoval, go ahead.
Thank you. So just to add a little to what the director provided, we do look at different factors such as the information we obtain from the survey. We look at other surveys that we receive. We look at incidence and prevalence of disease in counties and at the state level. And then we turn to evidence-based strategies so that we're using the funds that we have in a responsible way. We want to be good stewards of the funds that we receive. So we want to make sure we're implementing programs that work. And we do this, as the director said, in a variety of ways, whether that's in conjunction with our public health nursing office, in conjunction with the healthcare provider office, if they're interested in looking at something like diabetes and diabetes prevention, cardiovascular disease prevention, et cetera.
Thank you, Senator Larson.
Yeah, Mr. Chairman, thank you. I just keep hearing about a telephone survey. Is that a one time during the year, or do you do that over the months?
Mr. Chairman, Senator Larson, that I believe that is an annual survey. Stephanie can correct me if I'm wrong. So the data is lagged. But it does get a representative sample, and it's something that every state participates in. So we have some control over the questions we can ask or add to in that survey. So it's not something that we use to mobilize, change on a week-to-week or month-to-month basis. It really is to look impressionistically at trends in behavioral health and physical health and in healthcare access, how people are responding. Can they go to the doctor? Are they close to a provider? What are they struggling with? How much do they drink, using substances, et cetera? But as with all surveys, you have to take them with a grain of salt. I'm comfortable with, survey methodology, but it really does warrant some impressionistic sense to see how the state is trending. And I think that's one element that can help support how we select priorities in different communities with these programs.
Follow up? Mr. Chairman, thank you. So it's kind of a national survey contracted out by, to be done, I guess, across a couple states or such.
Mr. Chairman, Stephanie, will you weigh in on that? It's not really a national company that's doing it. It's really a national-based survey that states implement on their own. But Stephanie, please correct me if I'm wrong.
Sure. Mr. Chairman, thank you. Representative Larson, the survey that is done is for Wyoming residents. Each state receives separate funding to conduct these surveys. As the director said, we are able to customize the survey to some extent. However, the information that we collect is then, comparable to other states. So we want to make sure that we're asking many of the same questions so we can look at our trends compared to other states. But that funding does come directly to Wyoming. We then have a contract with the provider who initiates the survey, and then that information and data comes back to us. We can then use that to inform our prevention efforts across the division and as appropriate across the agency.
Thank you, Ms. Sandoval. Any further questions from the committee? Let's proceed.
All right, Unit 539, this is injury and chronic disease prevention. So we've touched on a few items from this unit. Additionally, funding in this unit provides support for our injury prevention programs and some of the chronic disease prevention that we've talked about. Programming in this unit relates to the prevention of unintentional injuries like falls, as well as intentional injuries like suicide. We work in communities to provide education to seniors as well as to youth as they become new drivers. And then our chronic disease prevention efforts are also housed in this unit. And again, as we've discussed, we work on efforts related to diabetes prevention and cardiovascular disease prevention as examples. And we work on those through healthy lifestyle changes. And as I've mentioned, we work with a variety of entities and local communities to promote these programs. And I'll pause for questions.
Thank you. I do have a question myself. Injury and chronic disease. Wyoming is a rough state to work in. We've got a lot of risky jobs, oil field and other such things. We also have some activities that we enjoy that involve a certain amount of risk. And I'm just curious, do you work, for example, with OSHA and cooperative efforts to try to give information?
Mr. Chairman, thank you for that question. We actually do. We have a great partnership right now where we're trying to get the word out to different industries on just a variety of safe behavior and healthy behavior. So that's been a really great program that we've been involved in. So we are working across state agencies with that to really help our industry partners, help them get the word out to their employees on healthy behaviors, unhealthy behaviors, how they can reach out for assistance if they need that. So we're really actually very proud of that program and just proud of the efforts that they've been able to engage in across state agencies and into the industry.
And I won't belabor the question. I've already asked it a couple times. So this is kind of rhetorical at this point, but who gets to decide what's healthy behavior and what isn't? So any other questions from the committee? Oh, according to Representative Sherwood, mom is the ultimate authority. I think she's right. Any other questions then on that? Okay, please proceed to 540.
All right, Mr. Chairman, Unit 540 is our infectious disease epidemiology unit. This unit works to conduct infectious disease surveillance and epidemiologic follow-up and investigation of cases, clusters, and outbreaks in order to monitor occurrences, trends, and risk factors for diseases that pose a threat to public health and to mitigate risks to public health. Our team in this area looks for early warning signs of disease spread, provides guidance on preventive measures, and gives recommendations to impacted individuals to reduce the impact of infectious disease on our communities.
Committee?
I'll pause for questions.
Yeah, committee. Okay, just for those out there watching, for those in here listening, we'll take public comment here basically on this whole public health section following this. And if you have a comment, I would ask you to try to qualify it by what unit number that is so that we can keep our file straight in our own mind. So we will close out your portion here with number 550, substance abuse, tobacco prevention.
All right, Mr. Chairman, Unit 550, as you said, is our substance abuse and tobacco prevention unit. This unit works to prevent overconsumption of alcohol, opioid misuse and abuse, and other drugs, and tobacco prevention. And as some of you may recall, we worked back in 2018 to redesign how prevention services are delivered in our state. We did that through a partnership with many stakeholders, including legislators, county commissioners, and other partners across the prevention spectrum. So we now make funding available to local communities. Every county participates in this program, and we offer technical assistance to our partners in this area. And it just so happens that these partners from around the state are here for their annual fall meeting. And I do just want to wrap up and indicate the reason I say we is because I'm so proud of our team and the work that we do here, and I couldn't do it without them. So I appreciate just a moment of indulgence for me to mention that. And with that, I'll stand for any additional questions on Unit 550.
Okay, I do have to fill in the question gap. When we look at substance abuse, tobacco prevention, virtually all of my life, I've heard about programs, either federal, state, local, to curb these issues. I would say in some cases there's been some progress. In other cases, it's hard to tell. How do you measure? How do we determine a return of investment on our efforts to curb these issues?
Mr. Chairman, thank you for that question. And you're right, we have seen a variety of trends in these areas. Some of our trends are moving in the right direction, such as tobacco prevention. Others we continue to work on when it comes to substance misuse and abuse. How do we know? We want to look at a variety of factors. So we want to look at risk and protective factors that communities have in place that are those factors that help people to make the right decision as opposed to the wrong or harmful decision. We can look at ongoing trends over time. With our prevention work, we do look at local efforts and what those local issues are that our prevention specialists are facing. And we work with them to try to look at how they're delivering those prevention tools and trends. And then we do also have evaluation programs for a lot of our work in the prevention area. We're happy to share that information with the committee.
And Mr. Chairman, if I may add, you all have no idea how much we debate this internally in the Department of Health when it comes to performance. And Stephanie's probably going to hate me for bringing this up, but ever since I've been here, and I know ever since she's been here, it's difficult to measure performance of any sort of prevention program. When you're looking for how an intervention caused something not to happen, just that whole causal connection is just very difficult to demonstrate. And the question is right to bring up, what's the return there? We do our best, and like we talked about offline, happy to share our kind of performance data at the department level with what we're looking at, both in terms of the outcomes we're trying to see and trends, but also in the value chain of these types of programs. How much are we putting into something versus what we're getting out of it? So how efficient are we being with the widgets or the trainings or the materials that we're putting out there? You can look at performance that way just on the basic operations of it, but it's philosophically just a challenge. And I think Stephanie's right that we've moved in the right direction on a number of measures, and tobacco use is a great example. Nationally, we're just seeing some phenomenal trends, and I think the interesting question is how much of that is related to programming and public health work that has happened versus natural societal trends away from something and maybe moving to something else. I just want to be honest and blunt that it's just really hard to draw those causal connections. However, it's also important to mention that with something like suicide prevention, what drives that prioritization to some of the questions you asked earlier is rates, observations we see of these things coming out in society. And being a state that has historically had a high suicide rate per capita, and just the devastation that that type of event leaves on a family and a community, there's almost we're compelled as a society, as a state, as a legislature, executive branch to do something. And so some of that prevention work, I think, is more naturally derived than others. But just want to be clear that it's something we really try to work on. We will, as Stephanie mentioned, share as the committee is interested. Don't want to overwhelm you with the type of performance data and trends that we look at, but it's a difficult challenge to really demonstrate causal connections in some of these areas.
Senator Larson.
Mr. Chairman, thank you. So I heard some mention about keeping track of these records or whatever, or stats or whatever, but are we getting out on the ground and going to schools? Is that part of this program? Or are we teaching the teachers, or what are we doing?
Mr. Chairman and Senator Larson, to clarify, specifically in Unit 550, substance abuse and tobacco prevention, is that the question? In general, yes. I'll let Stephanie elaborate on some of those details of where these resources, trainings, community outreach is deployed. But obviously, with youth initiation of alcohol, drug use, tobacco use, absolutely involves on the ground folks connected to the schools and school districts. But Stephanie, please add anything I missed.
Sure, Mr. Chairman, Representative Larson, our prevention funding that goes to counties, that is used to fund a community prevention specialist. And that prevention specialist often works with a number of members who sit on a coalition in a community, and that often does include school districts. So many of them are developing these partnerships over a wide sector and range in the communities to help make sure those prevention efforts are really hitting all targets across the community.
So I've got a couple of things here. One of them, okay, we've made some ground over the last 40, 50 years, and I say we collectively as a nation on tobacco use. But as soon as you talk about playing whack-a-mole earlier, now we've got all these other things coming up. And it seems to me that you're chasing a moving target. And what was a difficult thing to try to measure is only going to be even more so as it goes on. So I guess you should end that with, wouldn't you agree?
Mr. Chairman, I'll carefully answer that with, I think so. Yeah.
Fair enough. Now I want to throw an observation out and a question, and there may not be an answer to this right away, but I noticed something interesting when we were clear back here looking at the cross section on slide 36. Behavioral health centers are much thicker in the western half of the state than in the eastern half of the state. And so the question then, and I bring it up now because it may possibly relate to some of what we're talking about. Do we find that suicides or issues with drugs and things are more frequent in the western half of the state than the eastern half of the state? Or is it just that those centers are there because it's more difficult terrain? So how does that work?
Mr. Chairman, that's a really good question. I think I don't, let me look into the numbers on if we see, interesting correlations there. I don't, nothing comes to mind in terms of why those centers exist there. I think it's more both an artifact of, history of how centers developed, how the state developed them going back to the 1970s, and also, through the state funding of trying to have coverage in every county. So I think it might be a little misleading to look at more density here with what those different stars on that graph, the catchment areas they're covering, and the types of services they provide. But happy to look at that in more detail and get back to the committee.
Thank you. I just found it interesting that geographically there's, was it Lincoln County, I think, has 3 and others. Come on up. And I look at that, and as we're trying to analyze, especially when it comes to suicide and that tricky thing, maybe there's something that we've missed, or maybe somebody's already seen it and we haven't shared it well. So, yes, sir, please introduce yourself and bring your comment.
There we go. Kip Dana with High Country Behavioral Health. I'm one of the representative stars throughout 7 of these counties. And Mr. Chairman and committee, just like to address the star question. The state contract with the Wyoming Department of Health requires us to have a facility in every county open 40 days or 40 hours a week, available for people and able to respond to emergencies. Where you see multiple stars, like Lincoln County is one of my areas. One of those stars is Thane and another star is Afton, 20 miles apart. And it's just that I've chosen in that community to have a Thane, Afton, and Kemmer office open. I don't have to by our contract. And then when I get over to Uena County there on the bottom left, I've got one out in Bridger Valley and in Evanston. So it's not that we have a greater population density. It's just that we have, some of us have chosen, like over in Sublette County, I've got a Pinedale office and a Big Piney office. I don't have to, but rather than have people from Big Piney and LaBarge drive into Pinedale, we've elected to have multiple offices in these communities. So it's not really a representation that there's more money or more resources. Just some of us have chosen to put more access with less travel.
Thank you for that insight. It's helpful. I just found it curious. I knew there wasn't necessarily more people over there, but it could be it's difficult to get from one side of the county to the other, especially in the
That's
winter.
primarily it, yes.
That's helpful. Just wasting time, I guess. Any further questions on any of those topics? Okay, seeing none, we'll move on to public comment. And I'll begin public comment. Anyone in the room, and again, we're talking about all of public health. And so if you have a comment on, for example, WIC, please identify that as it would begin. Come on ahead if you have a comment, introduce yourself, tell us what we need to hear.
Good afternoon, Chairman and members of the committee. My name is Anna Kinder. I'm the Executive Director of the Casper-Natrona County Health Department. Thank you for the chance to speak to you today, and I recognize the challenges you have ahead of you. I want to first off answer why public health matters. Public health is often invisible until something goes wrong. Restaurant inspections to prevent foodborne illness, vaccines that keep our community members healthy, case investigations, or emergency preparedness. Every resident benefits, and we are the first line of defense when crisis hits, whether from communicable disease, natural or man-made disasters. We're trained, ready, and on the ground often before many others. Our work is fiscally responsible. We pursue other funding from other sources when we're looking to meet the needs of the community, and we utilize the funding from the Wyoming Department of Health to provide statutorily required services. I would also like to stress that investing in prevention saves money. Every dollar saves up to $5 in downstream costs. We look beyond individual patients. We track trends, noting increasing chronic disease, rising overdoses, emerging infections, and act early to protect community safety and well-being. We also look at internal and external violence. We have an independent county model, which Natrona is one of 5 independent counties, as the director described earlier. Independence allows us to pivot quickly, tailor programs, and meet the unique needs of our community. It means local accountability and local efficiency. Our funding was frozen at 2014 rates. It covers about 65% of the salaries for a limited number of nurses. In 2024, you passed House Bill 74, which added Wyoming State Statute 35-1-243F. That statute requires the Department of Health to adjust county contracts when state nursing salaries are increased. However, the appropriation to fund those adjustments did not pass this last session. Our funding is very fragile, and cuts will result in reduction to services. We do have an exciting thing. We are building for the future. Natrona County is preparing for the future. A new health department facility is underway, made possible by a land donation from the city of Casper funding through congressional directed spending, SLIB ARPA funds, Natrona County ARPA funds, and general funds. This is a once-in-a-lifetime generation investment that will ensure modern, efficient, and collaborative public health services for years to come. I invite you to visit anytime to see the intentional and innovative design to meet the needs of the community and the staff providing those services. We have many services. I'll only highlight some. You asked me to reference the numbers on the sheet. Basically, it would be easier for me to say which ones we don't necessarily directly do. We do a number of them. We provide environmental health inspections, communicable disease control through prevention, education, and treatment, immunization, cancer prevention, maternal child health programming, Ryan White case management, adult health. We recently added WIC to our services. We have behavioral health prevention, outreach to downtown populations and those experiencing challenges accessing medical care, and emergency preparedness. We're also participating in a very large community behavioral health response. Each of those services saves money, protects lives, and builds a stronger, healthier community. Public health is not a luxury. It protects taxpayers, stabilizes the workforce, and keeps communities safe and thriving places to live. Thank you. I'll answer any questions if you have any.
Questions? Thank you.
Thank you. Look forward to additional conversation.
Always up for conversation. Anybody else in the room comment on any of the public health? Welcome, Mr. Sweeney. Please introduce yourself for everybody and tell us what we need to know.
Thank you, Mr. Chairman and subcommittee members. My name is Pat Sweeney, and I wasn't intending to talk, but on what the exercise that you're going through, I think is very important in looking at the overall budget for the Department of Health. And I'd just like to, I'm always amazed by our director, how he keeps that much information in there without his head exploding is remarkable. And also LSO's memos to you, that is a doctorate dissertation in itself, the one piece. So congratulations on that. As you go through this, having spent 4 years on labor health and looking into basically our WICHE program and some of the other things with family practice on a subcommittee and trying to become more efficient, I soon realized there wasn't a lot of efficiencies to gain. And I think it's good exercise and a good practice to go through, but I don't see where you can, honestly, in my opinion, cut, say, public health to preserve more funding for developmental disabilities. And as Mr. Chairman, as you've already stated, you don't want to cut anything. But if we could keep at least a steady funding source of some sort, I think it's very important. And all of these divisions, all of these programs are vital to all of our communities. Unfortunately, I can't stay to talk about the aging division, which I'm very much a part of. But because we're having a special city council meeting tonight, but as you go through, I guess my recommendation is we have to be careful on what we're doing. And because they all have consequences. And if we can keep a steady hand, and you've got a great crew leading the charge for the state, I honestly don't think there's much better in the country. So waste, fraud, I don't see it, but maybe there's some there. And a few years ago, Senator Burchard felt that there might be a way to, within a separate audit function, not part of the Department of Health, but maybe under the state auditor. I'm not quite sure what he had in mind, but, and it was because of a case of, I think it was, I can't remember if it was Medicaid fraud, but that didn't end up well, and he felt that it could be handled differently. But maybe that's a different direction that appropriations could look. But so thank you with that.
Thank you for coming. I appreciate your being here, especially with your background, your experience, which leads me to ask, were you a part of either of the reductions in 2017 or in 2021? Did you play a role in either or both of those?
Mr. Chairman, yes. In neither one we had much of a choice, and especially with the pandemic and during the pandemic. And Department of Health did an unbelievable job trying to manage that. But did our citizens suffer because of it? Yes. And the only other thing I'd leave you with, Mr. Chairman, is it would have been helpful, and I made a lot of phone calls this morning after I saw the direction the committee was taking with public testimony, trying to get folks down here like hospice, and so that you had some real life testimony. But, you know, maybe give us a little, some of us out here in the hitherlands, you know, what to expect at the next meeting before you adjourn today would be helpful.
We'll be covering that before we close, and I do have some ideas. I want to hear from my fellow committee members where we want to go. But I do have a further question for you. Looking back at those reductions in 17 and 21, do you have any large regrets? Do you feel like, man, we really messed that up? If you had it to do over, would you have changed any of that? Is there something that you did that you think was just not the right thing?
Thank you, Mr. Chairman, for that. You know, my memory's failing, which is a good thing with this question. But one of the things that I think we could have done and should have done a little bit more deliberately was, you know, taking a look maybe a little closer at whether it was public health or whether it was, you know, our like Central Wyoming Counseling Center and some of those reductions. I think we could have been maybe a little more strategic than across the board. But Director Johansson was there for all of that, and he probably has got a lot of good information stored up there on that. So.
Thank you. And I will be posing that same question to you, but probably offline or whatever, so that we can take the time to really go through it. But I appreciate your being here, and I appreciate your service to the state.
So thank you, Mr. Chairman.
Anyone else in the room? Seeing none, do we have anybody online? That's great, because I'm ready to take a little break. We're about 10 minutes or so behind where we wanted to be, maybe more. But that's okay because we're in the public comment part. And one of the things that I really wanted to do was to get as much input as we can from the public. And like I said, there will be another meeting later where we do that. So let's take 15 minutes. Let's come back at 3:25 and we'll take a break. Hear ye, hear ye. Let's get back to work. Are you good to go over there? All right. We are now moving to behavioral health, and I will preface this by saying I think most of us in the legislature have heard a lot about this topic over the last couple of years. And that doesn't mean that there's more that we shouldn't learn, but it does mean that I don't want to hear the same things we've been hearing for the last 2 years. If you have something new to bring to the conversation, by all means, please do so. And it's fair to reiterate a point or two, but we don't want to rehash what we've done. So that's my way of saying I'm getting hungry. And I hope this goes well. I have to commend Elizabeth Martineau. Her job on laying out the agenda, when everybody looked at the agenda, they said, you people are nuts. And it has gone very smoothly. She understands the process. She understands what went into it. And thank you for doing a tremendous job on that. And we'll continue from there. So we begin then under behavioral health with section or unit 2502, recovery supports.
And Mr. Chairman, with these next two divisions, I can be relatively brief. We've talked a lot about this in the agency overview, and I know your focus, rightfully so, on public comment at this meeting and the subsequent meetings is really a priority. So I'll be brief with some of these overviews, but please feel free to ask any questions if I should clarify anything. With 2502, this is our recovery supports unit and really is a support function for the subsequent units, the subsequent 4 units that we'll talk about with mental health and substance abuse. And so what this unit essentially does, it has a few very particular programs that work in conjunction with the larger, broader, and more macro funding for outpatient mental health, residential mental health, outpatient substance use, and outpatient mental health in the subsequent units. So this unit has a program called PATH, Projects for Assistance in Transition from Homelessness. It also contains our mental health ombudsman program, which is a requirement to receive federal block grant funding in mental health, and really is kind of a third party that advocates on behalf of mental health populations that may be institutionalized and have again kind of an objective third party that can advocate on their behalf. Similarly, this unit also contains funding for what we call guardianship services. And I know many of you in various committees have heard this issue over numerous years. Specific to the Department of Health, where I want to be pretty clear on the issue of guardianship that crops up for us, is largely in a couple of areas in our state hospital, our Life Resource Center, and in crisis cases that we deal with in conjunction with DFS and the Department of Education. Often some of these priority populations that really are acutely ill and also have quite a challenging social situation, history of trauma, abuse, et cetera. We struggle in many cases to find individuals to act as their guardian, especially when we have incapacitated or mentally ill populations that really are incapable of making decisions on their own. We do our best to find, through some funding that's provided here, guardianship services through Wyoming Guardianship Corporation as an example, but also through work that we do in with friends and family, the faith-based community, to see, can we have someone that will step up, and go through the legal process of being appointed a guardian by a court. There's legal filing fees that come with that can be a challenge for some of the populations we deal with at our facilities. And as I mentioned before, across really 3 agencies in the executive branch, we also have crisis cases, both with youth and adults, that frankly just don't fit neatly into some of the coverage buckets that we have, a lot of which we've talked about today, whether it's through Medicaid waivers, community mental health, DD providers, and you have folks who might be in Title 25, Title 7, Title 14, and DFS, where we really struggle to find an appropriate level of care. And in addition to that, you have individuals, for example, on the adult protective services side in DFS that, might not have a family member, a friend, or a guardian that can act in that role. So you'll see some of that funding in this unit as well. And finally, again, this kind of cues up the discussion on the next 4 units. We have something called quality of life supports that supplement our contracts with community mental health and substance use centers or behavioral health centers. And examples of some of those quality of life expenditures can include medications that might not be part of those contractual arrangements. Medical needs, transportation can be a component where our behavioral health centers can utilize quality of life funds to essentially handle some of those piecemeal or one-time needs that arise to keep that client in the community. For example, if transportation is needed to appointments, they can access some of this funding to supplement those contracts. So as you can see here, this is on page 239 of our standard budget book. And on page 241, you see the budget breakdown there. On the general fund side, it is approximately just under $1 million. And then special revenue, about $100,000. And then you have our federal funds, which include mental health and substance use block grant funds from the federal administration, kind of totaling out the bulk of this funding at around $4.8 million of federal funds. No positions are supported through this unit, but hopefully that description is enough of an overview. But really queuing up your subsequent units 2506, 07, 08, and 09 are the big budget item totaling nearly $100 million on the biennium for community mental health and substance abuse services. With that, happy to stand for any questions.
Questions?
Thank you, Mr. Chairman and Director. And could you refresh my memory about the general fund shift from about 4 million in 22 to then what we see today, right under 1 million? Or phone a friend.
Mr. Chairman, Representative Sherwood, I'll confirm this either before we adjourn today or shortly thereafter. Believe in one of the previous rounds of budget reductions, we hit this unit pretty hard on the general fund side. But I'll have to double check those numbers and get you that breakdown. Eric, I don't know if you know off the top of your head, but I believe it was budget reductions.
Any further questions? Director, do you have any further comments on 2506 through 2509?
Mr. Chairman, just very briefly, since we did hit those areas pretty hard in the agency overview this morning, that's approximately $100 million per biennium that funds our contracts with community mental health and substance abuse centers, or behavioral health centers as they're now referred to in statute. What I'd like to mention here is that in the recent couple of years, culminating in a full implementation July of 2024, we've implemented a comprehensive redesign to not only how we fund, but who we provide funding for community mental health and substance abuse. We went over those priority population categories this morning, really focusing now per statute on acute psychiatric adults, criminal justice involved adults, high needs children and their families. So think Title 14, DFS or DFS adjacent adolescents or kids. And then a high need, low income, under 200% of the poverty level population. The reason for that shift, Mr. Chairman, was really to address and bring together state resources to target a population that is very costly in other state systems like Department of Corrections, local county corrections, Title 25, DFS, and do a couple of things. One, prioritize them directly for eligibility for these services, really necking down in a conservative way who we're funding and why, getting back to our discussions previously about safety net or core services of what happens when the state does not appropriately care for early on these types of populations. You see them in your criminal justice system. You see them in the state hospital or in the Department of Family Services system. That was really the root of the comprehensive reform. I have to thank our providers, some of whom I'm assuming you'll hear from today in public comment. It's been a long road to get where we are, and a lot of tough decisions, a lot of business model adjustments to really transform who we're paying for and how we pay for those services. And I just have to say, as much as there could have been skepticism about the decisions that were being made, our community mental health providers have been with us every step of the way, helping design what I think is a successful implementation going back a little more than a year ago. In addition to the changes in who was being prioritized, we also made significant changes to the technical systems around that, how folks are made eligible, leveraging and combining the Medicaid technology system that you heard about earlier today, so that we're running non-Medicaid clients through the same eligibility systems, identifying other pay sources, third-party liability, Medicaid eligibility, so we can offset costs. That's been a really tough road to go down, both in my office, our behavioral health division, Jesse's office in Medicaid, and on the provider side, to completely change business practices. And it hasn't been easy, but I think the state long-term will be better off for it, because we're really working more efficiently and using more robust technology that we've built to work a bit smarter. So I just wanted to mention that I think our community mental health providers do excellent work. What I'm seeing in many parts of the state, both connecting to our priority populations at the state hospital who need to discharge into community services, our community mental health providers connecting with their jails, law enforcement, and judicial systems, both in terms of these new programs that are coming up with Title VII diversion, with jail-based services. I would encourage you to talk to your mental health providers in this system, and talk to your sheriffs in law enforcement, your county attorneys, that there's still a lot of problems to solve, don't get me wrong, but I really think over the past several years we've moved in a really positive direction, and I think our provider community is a really big part of that movement and change that I believe will be positive in the future. With that, Mr. Chairman, that I will conclude my comments by saying this is our second or third largest line item in the Department of Health budget, after Medicaid and our developmental disability and long-term care waivers. And so in previous years, going back to 2017 and 2021, this is a provider system that took heavy cuts, just like our Medicaid providers did, because we had to. And those were difficult decisions to make. The state revenue situation was unable to support. And to your question earlier, to former Representative Sweeney, this is one of those areas where legislature in some ways directed kind of an across-the-board methodology in many ways, really asking the department, hey, here's your number you got to hit, bring us a plan. And that those are tough. And it's also really tough on the other side of that coin to be targeted, because you're dealing with it in this subcommittee, which population, which provider group, which service, what infrastructure do you target if you're going to say, let's avoid across the board cuts and be more targeted? Those are tough and principled policy decisions that the legislature and the executive branch have to make to determine where, we have nice to have and not need to have services. But these four units, did take approximately 15% cut over those budget cut periods. And so we're in the, millions, if not tens of millions of dollars of cuts there. Even with all of that, I think partnering with us to implement these reforms to try to target these very tough to serve and tough to reach populations has been impressive. And with that, Mr. Chairman, on those units, happy to stand for any questions.
Questions? Is that a yay or no? Okay, so in putting my mind into how to approach this conundrum, and it is that, trying to make sense of it all in my own mind, I thought about different concepts. How do you look at how worthy are people? And that gets into some pretty tricky things, but I was thinking about the concept of, say, culpability. You find people who, like in my own case, I was born with a cleft lip and palate, and through no fault of my parents, no risky behaviors, and it's just a blip. It just happens. Things like that. No culpability whatsoever. Versus somebody who chronically does stupid things and gets themselves, who is more deserving? You got to cut somebody. But the problem that I ran into, and I would ask you to comment on this, the problem that I ran into is that's not really the way these benefits are structured. These benefits are structured so that the benefits may cross that spectrum of persons. So it's kind of coming at different directions. But when you were involved with previous cuts, did any kind of that thinking go into how you decided how to do what?
Mr. Chairman, it's a great question. And in general, yes. So as both of those rounds of budget cuts over the last 6 years or so happened, as I mentioned, the Department of Health was essentially directed to hit a number. And so many of those principles we did look at. I'll list a few. We looked at programs and services that might be, regional or localized and not statewide. For example, we eliminated a program that was adjacent to Medicaid called PACE, Program for All-Inclusive Care of the Elderly. It's a model that a lot of states have implemented and essentially provides kind of all-inclusive care in both home and community-based long-term care, but transportation to medical appointments, et cetera. Very popular program for seniors, for states and regions that have it. But it was only operating in Cheyenne, through partnership with Cheyenne Regional Medical Center. Very difficult decision to make a decision to cut that. But again, it was a regional only type service, relatively small in terms of the elderly population, but a very, very popular model. We did a study for you guys just a year or two ago to look at PACE, and we actually reached out to all of the former participants who were still living and some of their family members to survey them of where they are now, what happened. Happy to share that study with you. So things like that were definitely part of our calculus in making those budget cuts, as were things like, let's look at areas where we can offset general fund by maximizing federal funds. And I know there's different decision making or maybe perspectives now on which is fair on, federal funds are also taxpayer dollars. We all pay into that. But in terms of state prioritization, where can we maximize that revenue so that we minimize the human impact of budget cuts by, taking advantage of an increased federal match rate or a federal grant or something. And that comes with its own pros and cons as well, because all federal funds generally have federal strings. Please.
So I think that was commendable, and I noticed that when I was looking at the cuts myself, is, are we leveraging federal funds to the very best of our ability? Obviously, that changes year to year, administration to administration, and policies change. Was there anything built into your organization that continually monitored that and made adjustments as they came, or is it time to go back and revisit that?
Mr. Chairman, it's a good question. We, especially on the Medicaid side, where we have such a significant amount of federal funds, we're doing that continuously. And so you heard some of that from Mr. Springer earlier today, where we are constantly looking at, are we taking advantage of, protecting state funds at every juncture that we can. And I'm comfortable with where we are with that. That doesn't mean there's not additional, changes or tweaks that could be made. But that is a continuous process. But I do want to pick up on something you mentioned, that it's also difficult because not everything is like Medicaid federal funds, where it's essentially a match that comes in. You have other federal funds which are grant-based and can fluctuate from year to year. And we've experienced a lot of that in the administration turnover, where certain federal funding sources were shut off earlier than we expected. we plan for things like that. We try to be conservative where we can, to make sure we have transition plans. But in some of these cases, we're just cutting those funds off and notifying recipients this is no longer available. So again, temporary grant funds, even if you are optimistic and say we believe this will be reauthorized by the federal government, et cetera, that's not always a guarantee. And so we have to wade carefully into those waters. So again, Mr. Chairman, don't want to spin my wheels too much, but I think the principles that you mentioned in the several rounds of budget cuts that I've been a part of have obviously been top of mind when we're making those difficult decisions, but it's never easy.
Thank you. Any other questions? We're basically looking at 2502 through 2509. Questions from the committee? And I believe that leaves 2510, the preschool services, if we could round that out, and then we'll look for some public comment.
And Mr. Chairman, we talked about 2510 preschool services quite a bit this morning. These are again, our child development centers that provide services mostly on the special education side for children who are identified with developmental delays or developmental disabilities, ages birth through age 5. So getting to the budget unit, bear with me here. That begins on page 273 of our standard budget. This is another large line item in our budget book of approximately $93.4 million on the biennium. So these are costly services and involve federal regulation through the Federal Department of Education, state regulation through the State Department of Education. A fun fact, we are actually considered as the administrators of this program, the 49th school district by the State Department of Education. So it's a bit awkward. But at the same time, I think, the services that are provided through this program are necessary, and the intent behind it is to try to catch kids up developmentally before they enter the K through 12 system. And the real mission over time of this particular program has been to reduce special education expenditures in the K through 12 system. Like we talked about earlier with home-based services and long-term care, hard to draw those causal connections to say, are we truly, saving or offsetting funds? And Department of Health's answer over the years has been probably yes. It's good to have these early identification, early intervention services, especially on the special ed side, to essentially catch developmental delays and provide services to mitigate those issues. But again, this runs through 14 regional child development centers and has external cost adjustment provisions in the budget, as well as a child count that you all on JAC see. Fortunately or unfortunately from the Department of Health every year, adjustments to that budget. We are required by statute to bring those to you for your consideration. With that, Mr. Chairman, happy to answer any questions about our preschool services.
Yes, sir. Senator Larson.
Thank you, Mr. Chairman. So are there some education funds that go to these same development centers, and how do they relate?
Mr. Chairman, Senator Larson, it's a good question and timely, because recently, just in this biennium, we deployed something you all had appropriated a couple of years ago from the School Foundation Program account. And that's a mechanism the legislature has in its purview, in addition to general fund, when you're considering the external cost adjustment, the per child amounts. That was something that the JAC and the legislature, I believe 2.5 years ago, appropriated about $4 million of School Foundation Program account dollars into this program. They act as general funds from our perspective, but yes, they're education funds in that regard within your preschool services here. And you'll see that in the budget breakdown in special revenue, or SFP. Does that help, Senator Larson?
Mr. Chairman, follow up. Getting in trouble here. So are they included in this 75 million general funds? already, or is it on top of that?
Mr. Chairman, let our CFO answer that. I believe it's on top and coded through the SFP funds, but I frankly need some help with that one.
Yeah, Mr. Chairman and Senator Larson, we get approximately 8 million from education. So we get 4.3 million through what our director just told you, through the school foundation program funding. We also get another 4.3 million just directly from education. Both of those are listed under special revenue here, so they're not part of the general fund amount that you see of the 75 million.
Thanks, Eric.
Any follow-up? You satisfied?
Well, yeah, I think I caught it, Mr. Chairman. Thank you. I see over here on other funds, 9.6. Is that kind of what that is? Okay.
Other questions? I believe that wraps up the 2500 series. Thank you for that. Is there anyone in the room who would like to comment on one of these? Please come forward and have a seat, state your name, tell us who you're with, tell us what we need to hear. Start in the middle this time. Ladies first.
Thank you, Mr. Chairman. Good afternoon. Andy Somerville, Executive Director for the Wyoming Association of Mental Health and Substance Abuse Centers. And in the spirit of you guys get to see me all the time, I will keep this very, very brief. But I just wanted to bring up a couple of points. As you reviewing the budget, obviously it is the community mental health centers are a large item within the Department of Health's budget. The budget has essentially remained flat for the community mental health centers since 2002. That's when the last, I would say, large readjustment. There have been some slight increases and some decreases and budget cuts, but generally speaking, it has stayed in that 50 to 55 million per year, or about $100 million per biennium. And so what the community mental health centers have had to do over the years is provide additional funding sources, look to philanthropy, other partnerships, obviously change their services, work on business models, change programs, do all of those things over the years with the exact same amount of money going forward. So we have not cost adjusted them. And we're not here to ask you today to cost adjust them. It's just one of those things that it really it sticks out in terms of continuing to provide these services across the state with the same amount of dollars that they've had for quite some time. Specific to the behavioral health redesign, as the director Johansson indicated, that's been a very, very, very large, intensive project with a lot of work. One of the side effects of that project is, while many of the community mental health centers had pretty extensive partnerships in the community prior to implementing this, what behavioral health redesign has done is really, I would say, push that in a whole new direction in terms of really targeting these populations that are now required in statute. So behavioral health redesign has enabled some constructive relationships with police departments, sheriff's offices, courts, municipal circuit, district courts that weren't previously there, more community partnerships, more outreach, all of those pieces. And so now we're weaving what I would call a more complicated web in terms of trying to get access out, trying to reach these populations. And so there's, I would characterize it as a kind of a complicated relationship in terms of the community mental health centers are now providing services directly into places that they weren't maybe 10 or 15 years ago at the direction of the legislature in order to better serve their communities. All of those pieces. I think that's important to remember because there's a number of these partners that are depending on the community mental health centers to provide these services. And Mr. Chairman, you asked about, how do you quantify that impact? Is it human impact? Is it community impact? Is it state impact? One of the unique characteristics of the community mental health centers is that part of the behavioral health redesign mission is diversion away from state institutions. It's diversion away from the state hospital, life resource center, keeping people in their communities, Certainly working with the criminal justice population much more strongly now, trying to keep them out of jail or reduce recidivism. And so those pieces are required functions of the state. And so the question we always ask is, what investment do you make in community mental health so that they can divert? Does that save dollars down the line for the state? I think that's a question that I would ask you, everybody, to keep in their minds as you're looking at what is the return on investment for the budget. $100 million it's a large item, but what is it doing to produce savings for the state for required functions of the state anyways? If you cannot divert somebody from a Title 25, they will go through that process and potentially to the state hospital. If somebody continues to get in trouble, they may go back to jail, they may go back to prison. Those all come with costs. So, Mr. Chairman, I would just close my comments and stand for any questions. I know I've got a couple of other people that wanted to add some comments, but I'd be happy to stand for any questions.
Any questions? I think we're good. Thank you very much. Sir, it's yours.
Thank you, Mr. Chairman, members of the committee, for this opportunity. I'm grateful that you have public comment like this all the time. My name is Scott Hayes. I'm Executive Director of Fremont Counseling Service. We are one of the small but mighty community mental health centers in the state. I think we're the smallest one these days. We've been around for over 65 years. We provide the outpatient mental health, outpatient substance use services. But I want to highlight, I think in Fremont County, we have a pretty high volume of crisis and emergency contacts. It comprises, I think, a very significant portion of our work activity, and we do a pretty good job of it. And I know that we save the county money, and our diversion rate is very good, and our timely response is excellent. And in my 10 years since I've been executive director there, the number of crisis contacts coming into the center that require an on-call clinician response has almost doubled from the mid 500s a year to over 1,000 a year. And our diversion rate still hovers right around 80%. And of those, I can say that the people that we end up putting on a mental health hold, that number last year was somewhere between 160 and 170, which isn't a whole lot higher than it was 6 or 7 or 8 years ago. So we're really good about getting people where they need to go and doing it as timely as possible. And I know that that's a good thing for everybody concerned. And I just wanted to say that that's one of the things that we add value to our community. And in terms of I think Director Johansson and Andy here mentioned earlier, our partnerships have been spurred on. We've had good ones, but we really value those, and we need to do more of that. We have great, excellent relationships with our county attorney, the hospital system, our state partners in Casper and all across the state. Department of Corrections, DFS. We love working with them, and just wanted to say that's what we do. And with that, I'll stop and stand for questions.
Thank you. Questions? Thank you for your words.
Thank you, member of the committee.
The baton is passed to you, sir.
Thank you. Mr. Chairman, members of the committee, my name is Reverend Dan Odell. I'm the senior minister at First United Methodist Church, and I'm also on the board of directors for a homeless navigation center here in Casper called Kind Grounds. I want to speak just briefly about my support for our community mental health center, and especially its director, Jim Kauser. We found very in our collaborations, we've been able to make a big difference here in Casper. And we're seeing about 40 people a day at the navigation center for lunch and for services. That number has doubled over the last 6 months. And I just want to urge you not to cut any of the mental health behavioral health services because it affects my day job, which is at the church. And we're seeing about a dozen people or so now, which is up again from 6 months ago. We're seeing an uptick in requests for services, clothing, food, bus tickets, all of those things. And I would just end with this. I asked one of my county senators if, what are we going to do with the the nearly $10 billion trust fund? And I said, is there a possibility that we can use some of that interest to backfill, if you do make some of these cuts, if you can backfill? And the response I got was, well, we're so close to 10 billion, we're not going to touch it until we get over 10 billion. So if you have any pull with any of those folks, let them know that we'd love to see some of that interest spent on behavioral health services. So.
Thank you. You spoke of an uptick. Is that like a cyclical seasonal thing that comes back year to year, or is this an exceptional year?
I think it's not a seasonal. I mean, there are some seasonal upticks. When the COVID money ran out, with the increased cost for housing, I mean, we're seeing, 4 and 5 families trying to get together into a 2-bedroom apartment because they owe $3,000 and $4,000 to Rocky Mountain Power. They can't get places on their own. So homelessness is a very complicated issue, and every case is very different. But I think it's only going to get more expensive and worse as time goes on.
Well, I personally thank you for your efforts.
Thank you.
As a pastor, I think I understand some of what you go through.
I'm grateful for you guys. Sorry to interrupt.
No, that's fine.
Yeah. I'm grateful for your work with the state too.
Any other questions? All right. Is there anyone else in the room who would like to please come forward? Please reintroduce yourself. We just love how well you do it.
Thank you, Mr. Chairman, members of the committee. Once again, my name is Andy Schwartz, but this time I am representing the Child Development Centers. I think Director Johansson has done a very good job in describing a very complicated model. And I would just mention that it is particularly unusual in that the funding model is in the statutes with dollar amounts put on to 2 different categories. And Senate File 19, 2 years ago, you all saw that the funding model was changed, as he referenced. It's a very good thing, but it also includes the requirement for an annual ECA recommendation to come from the Department of Health. I can speak from experience on the Appropriations Committee and say that ECA is not always funded. And to the extent some years it was funded at 0. Part of this goes back to the budget cuts. There's a lot of reasons. I have no desire to discuss them, but I would just say that the good that these programs do is very difficult to measure. The director mentioned, for instance, that it's a huge benefit for the K-12 system because the earlier you identify these problems, a lot of them it's speech therapy or hearing aids, things that don't rise to a high level, but the difference it makes for that child education is huge. And then when they get out of high school, their ability to be an active participant in Wyoming's economy increases dramatically as well. I'll leave it at that, but with the indulgence of the chairman, I will make an unrelated comment. I recently became the lobbyist for the senior centers. I have to go back to my home for a meeting in the morning, so I will not be commenting on the aging division. To be honest, I've only had this job for a month. I'm not sure that I could give really informed comment, but I will be in touch with you all on that at future meetings, and I'll stand for any questions.
I do thank you for that. With the agencies, with those of you we see all the time and speak to each other, just because we close the section doesn't mean it's over, you know. My phone lines are empty. Nobody ever calls me. I never get any emails, so please indulge me and give me something to do.
Thank you, Mr. Chairman, and once I know more about it, I will be in touch.
All right, and please say hello to my friend Carmen. Anybody else in the room? Yes, ma'am. Go right ahead.
Mr. Chairman, members of the committee, my name is Rachel Bozis, and I'm with the Natrona Collective Health Trust here in Casper. We have a coalition called the Natrona Council for Safety and Justice, and many of the folks in this room today are members of that. It coordinates law enforcement, it coordinates our hospital, Central Wyoming Counseling Center, WBI, so many of our nonprofits, and it helps. We work with our substance users in the community, justice involved individuals, as well as justice involved. So, and our aim is to reduce the financial cost as well as the human cost of substances and incarceration. We were working to reduce Title 25 designations. And I wanted to just bring your attention to this committee that we've started. And I'd like to invite you all to our summit that we're hosting on November 6th. If you are available to join, it's a good opportunity to learn about how we are bringing all of those different organizations together to address this population, if I may.
If you would just give it over here to the LSO folks, they'll make sure that it gets out to us. And I thank you for the invitation.
Yes. And with that, I'll stand for questions.
Yep. Any question? You good? All right, thank you.
Thank you.
Ma'am?
Mr. Chairman, members of the committee, Lindsay Simino with the Wyoming Behavioral Health Alliance. Forgive my tardiness. I was able to listen for most of the day, so my comments will really kind of encompass everything. One of the things that was brought up earlier was the idea of what causes regret when it comes to these budget cuts. And we know that anything is up for discussion this budget year. However, being around for the 2017, I did want to emphasize our community prevention specialists when it does come to the behavioral health funding being flatlined, as Ms. Somerville described for several years. They have really been essential in helping us know what the community needs are, what the county needs are, and really helping support that behavioral health line item. And so if you are looking at kind of the system that is the Department of Health, the community prevention specialists, I think, are a major part of that. You guys have hard decisions to make. I would say, though, that from that initial cut in 2017 to that line item, that prevention line item, we saw a dip in a variety of different services across the state that we were able to then pick up with that COVID money and make hay, as they like to say, in our great state. And we got to see those suicide numbers begin to dip in 2022 with our call centers. And so we would hate to lose any progress that we've made since we've been able to make that progress with that funding. But we also recognize the situation you're in, and I thank you for your time.
Thank you for your understanding. Thank you for your testimony. Questions? I see none. Is there anyone else in the room who would like to bend our ears? All right. Do we have anybody online? We do not. With that, we are ready to move on to the 5,000 series, the aging. And first section is 5,002. This is one of those topics that I think every one of us faces eventually. Oh, Welcome back, Director. We missed you.
Thank you. I told them no questions in the hallway, but they listen. Mr. Chairman, it actually be very.
That is correct. And you have leave to do. So that's correct. You have leave to do whatever you think is appropriate.
Thank you, Mr. Chairman. The next handful of units, with the exception of the last unit 5010, can take a similar approach with the Behavioral Health Division. We discussed these programs in detail in the agency overview this morning. Units 5002, 5003, 5004, 05, and 07 are all part of our community living section. The section that in our overview we mentioned administers both state funds and federal funds related to senior center programming. So it's a variety of services mostly delivered through senior centers, but not always. For example, we have legal aid for seniors that is a very small contract for essentially free legal services with various elements that seniors might be dealing with their estates or guardianship or placement services, et cetera. But mostly these units fund nutrition services, activities, home-based care in some circumstances, to essentially with the mission of keeping seniors as long as we can, or as long as the community can, in their home or community-based settings, and delay or defer, institutional placements in nursing homes or other facilities. So I'm happy to go through the detailed budget, Mr. Chairman, if you would like, but we did break that down in the agency overview. So perhaps I'll pause here before the final unit and see if there are any specific questions about these services.
Questions? I would like to know a little bit more about the types of legal aid. I mean, one might assume that we're dealing with wills and estates and things like that, but please give us a little bit of information.
Mr. Chairman, you're right on the mark there. That's a big part of what I think folks through that type of service are requesting or needing. But in addition to that, you also have certain circumstances where a senior and elderly person might be experiencing abuse or neglect or something of that nature, being exploited financially. Those types of things. And in addition to state services available through adult protection services in the Department of Family Services, this is a mechanism that can offer some free or low cost legal services, which for some can be hard to access, and even navigating the legal system can be a challenge for those who might not have had estate planning or that type of service through their life. So it is a little bit of a mixed bag. We're happy, Mr. Chairman, to share with the committee our performance data and overview of some of those specifics. For example, legal aid. We have all that. I don't have it right in front of me, but can absolutely produce that for the committee.
I would be interested in seeing that. So whenever that's appropriate is fine. Senator Larson.
Mr. Chairman, thanks. 5002 senior care. I see we have a federal funds in 23-24 was 12.4 million, and then it dropped to 5.4 in 25-26, and just kind of wondering what went on there.
Mr. Chairman, Senator Larson, I'll have to dig into the details there unless our CFO has that info off the top of his head. You will, just spoiler alert, see a budget request for all federal funds this year at our budget hearing in JAC. We do have unspent federal allocations across some of these budget units in those Older American Act programs. For a variety of reasons, we didn't have the spending authority for them, but I'm not sure what caused that drop in federal fund revenue, but we can get that information very quickly.
Seeing no further questions, I think we would then be ready to look at healthcare licensing surveys. As a former nursing home manager, I can tell you that makes my blood run cold when you say survey.
Mr. Chairman, operating 5 24/7 facilities also gives me some anxiety when you hear all things licensing and survey, but I'm in a unique position because at the same time have that function in another part of my department. But just as maybe adding to the overview from this morning, this unit, which is housed in the aging division in the budget, actually in recent years, in the last 2 or 3 years, I've moved it into the director's office. Just hasn't been memorialized in that change yet in a budget request or through Chapter 17, but we plan to do that in the future. This unit, as I mentioned this morning, oversees all state licensure of certain healthcare facilities, and you'll see the statutory references throughout the budget book where you can find those. You can find the listing of those types of healthcare facilities that have state licensure components. It's not everybody. For example, we don't license or regulate a dentist office. That's not part of our statutory authority under state licensure. But a few of those facilities that I mentioned before, hospitals, nursing homes, boarding homes, assisted living facilities, ambulatory surgical centers, are part of that state licensure, really on the construction and life safety side. So a couple of examples there: when a facility wants to, add a wing or a room, or even things as simple as, changing their facility, moving sinks to other parts, we will review construction plans. So it can be major or minor. Obviously, the minor ones are relatively quick and easy if there's not major code issues or life safety issues. But in terms of new facilities, that work is more intensive. For example, I know there was a ribbon cutting for the new hospital in Pinedale just recently, and we've been heavily involved in that process, both in terms of construction plan reviews early on in the process. We provide a service so that we don't have too many gotchas at the end, where we will review initial plans and say, wait a second, before we approve this, address this list of concerns that we have, so that again, a community doesn't invest millions of dollars in a new facility and then we say at the 11th hour, oh, you got to change all of this. In addition to that, we will do final inspections on state licensure, life safety code, et cetera, for the state license for that facility. And Pinedale's a good recent example of our engineers and our surveyors working with that hospital. On the other side of OHLS, or Office of Healthcare Licensing and Survey, as I mentioned this morning, we enforce conditions of participation with Medicare and Medicaid. So we certify providers to be able to serve that population in the setting that they operate. So again, hospitals, nursing homes, certain types of providers that have that funding or serve that Medicare or Medicaid population. We essentially act on behalf of the federal government, of Centers for Medicare and Medicaid Services, or CMS, to do that certification work and compliance work. In addition to that, we investigate on behalf of CMS complaints related to facility-based, abuse, neglect, et cetera. And so we are constantly investigating those. We provided some data in the overview presentation this morning of kind of how many of those that we do. But I'll mention, both in terms of the state licensure, construction plan reviews, on-site surveys, both in the state and the federal sense. This is a difficult unit to staff and manage, and I'm happy with and proud of Laura Hudspeth, who's our administrator, and her entire team, because these folks are on the road a lot. It's one of those positions you advertise and say, here's the salary we offer, and are you okay with being on the road in Wyoming basically Monday through Thursday, all the time? It's not quite that standardized across the board, but these folks are constantly on the road, and I think you really have to have a lifestyle and an interest in that type of work to incorporate that much travel. To that end, we also try to recruit surveyors in their particular areas that are based outside of Cheyenne, so that the logistics are a little bit simpler. So folks based in Casper or Buffalo or the Bighorn Basin, and we're successful from time to time in doing that. partially so that we can have better retention of our staff, but also it's so much better for those communities when you have Wyoming people in those areas that, you establish that face-to-face connection. And Chairman Pendergraft, as you mentioned, a lot of the work that happens here, it's not the most pleasant news you receive after a survey that you're out of compliance with something, or that you're being penalized, or there's a corrective action plan, or even a civil money penalty. And I think it's a real benefit for the state of Wyoming to have this office, outside of the federal government sending contractors in, so that we can work a little bit more proactively with our healthcare facilities and our healthcare providers to try to get them to compliance, as opposed to just penalizing non-compliance. But having said that, we have a job to do, and we're often in that position of having those unfortunate discussions, and acting as a true regulatory entity has to in some circumstances. With that, Mr. Chairman, I'll close by saying we struggle with the federal government here in the funding that they, in my view, should allocate to support what are often state subsidized salaries. A lot of that funding hasn't changed in many, many years, and many other states have this complaint too, so we're not alone in that. But you can definitely see it in the budget breakdown that we do support a lot of this effort, and for good reason. On the state licensure side, that is a state function. But on the federal side, we're constantly engaging with CMS, and I think they listen. But it really comes down to a federal appropriations issue of how much resource can be allocated to support what is essentially federal work, important work, but really at the behest of the federal government. With that, Mr. Chairman, happy to answer any questions about healthcare licensing and surveys.
Thank you. I can tell you that if you look up thankless job in the dictionary, it has surveyor. Nobody wants to see you drive up. And at least 25 years ago, your people were very thorough. Senator, any final questions there? Representative Sherwood? No. I do thank you for that. That will close out that section. We'll take some public comment on this. And then I did have a question on another item sent in from another legislator that I would pose to you after that. And then following that, basically we'll move things behind the dais and we'll have a discussion about where do we go from here? What are we going to do in the next couple of, they'll actually be Zoom meetings indirect. And your input is also, and I know you're eager to hear what it is that we want to go to next. So we'll have that discussion and we'll do that openly. So that having been said, is there anyone in the room that would like to comment on these aging subjects? Yes, ma'am. I don't know what you would know about aging, but Representative Conley, welcome.
Thank you, Mr. Chairman. Representative Conley from House District 40, which has an absolutely amazing senior center. And it supports 2 communities, and the meals that they provide, transportation program, they call it the BATS bus, Buffalo Area Transportation. And there's a KC one as well. Home health based programs, activities of all kinds. Serve as companions. There's a companion program. They work with having older folks read to school-aged kids. It acts as somewhat of a call center for resources. People have questions, they move into the community, where can we go for this or that? They handle a lot of those calls. They said it's a hub of the community, and even with the funding that they have, they're still always doing different events. And example would be like a pie auction where you go in and pay $250 for an apple pie. And things like that to raise money to help support their facilities so they're not just there with their hands out. And the Department of Health does a tremendous job at helping to fund the nutrition program and different program. Oh, another thing they do too is help people with their Medicare. So when it's time for them to look at signing up for Medicare, there's a service there at the senior center where they can get help with that. What I'm saying is these are very important entities to our communities, and I hope the funding through the Department of Health continues.
Any questions from the committee? Go for it.
Thank you. Thank you, Representative, for being here and sharing your passion for the work our seniors centers do. In your opinion, are there the proceeds from the pie sales or those private fundraisers, are they earmarked for just general expenses, or is it specific to maybe transportation? Is there a theme of like where that gap exists?
You know, I'm not sure where it all goes, but I know our senior center does things like maybe take a bus to the Black Hills or take a bus trip up the mountain to see the wildflowers when they bloom, or things like that. So I might be speaking out of turn, but I think they use it a lot for that kind of thing as well.
Thank you. I know the senior center in Sheridan has what they call a day break, because you have people who are night and day caring for a loved one, and you need a break. And that is one of the most amazing things that I think happens, at least in Sheridan. Does that happen down there in Buffalo as well?
To a degree, yes. They have clients that come in and somebody plays cards with them or does something to try to, you know, give them something to do so that their caregiver can have a little break. Yeah.
Thank you. Any other questions? Thank you for your comments. Well
You're
received.
welcome.
Anybody else in the room? Do we have anybody online? Nobody online. That means that will conclude the primary agenda purpose of the day. And we will, at this point, I think we've given public comment all day, and to be able to say, is there anybody else who wants to talk about anything, might be a little bit overextended. But if I may pose this question, this is from another legislator earlier in the day, and I did not see it until recently, and if you don't have the direct answer to this, I'm sure you can send us in the right way. But the question is, how long children adopted from DFS care, how long do they receive benefits like medical, Medicaid, and food stamps? And is that funding covered through IDEA, or how does that work?
Mr. Chairman, it's a good question, and Jesse can provide additional details if you need them. Our former foster care category in Medicaid, I believe, provides coverage until age 26, and so that's the timeline that Medicaid coverage would be provided for that category, unless after that time period another categorical eligibility criteria was met for Medicaid. So until age 26.
Are there criteria to disenroll someone before that, should their circumstances change and they don't really have a need for that benefit?
Chairman Pendergraph, so there's two options here. So there's kids that, you know, they were with a foster care family, and that family actually decides to adopt them. That's called a subsidized adoption. So those kids and those families actually, as they apply for it and they want to keep renewing it, they can keep getting healthcare through Medicaid, because, you know, that's a cost that family is taking on as an adoptive family. So there's a whole program for that that's, to us, looks just like foster care, essentially. So those subsidized adoptions stay on the Medicaid program, so the family's not actually absorbing those healthcare costs and making the adoption not feasible. Once kids age out, they can stay on their parents' health care, possibly through, you know, just regular private insurance, or they do have, some of the kids don't have that. So when they're aging out of foster care, they can go on to a group called former foster care, which goes to age 26. And they just apply and they keep renewing, and it's available to them. But just like anything else, if they have employer-based insurance and they prefer that, they can drop that coverage if they choose.
Thank you. I believe, unless there are any other posing questions, that we are finished with that section. So thank you for today. It was very helpful, at least to me. And I appreciate your being here and enduring.
Mr. Chairman, if I may, just in closing, I want to thank this subcommittee for your time. I know Department of Health is a large, complicated budget and probably scratched the surface today. As hope goes without saying, members of this subcommittee or anybody in the legislature can reach out to me anytime. I have no life. This is what I love to do. And we look forward to the subsequent meetings and in what would be most helpful to the committee. So both in those meetings or offline, please feel free to reach out. We're happy to get together offline and show you what we have, try to be as transparent as possible in the operations of the health department, but mostly just appreciate the opportunity today. It's never easy decisions when you're dealing with the Department of Health budget, but hopefully shed some light on some of those important topics today. So thank you.
Thank you. You're welcome to remain seated there if you'd like. We may have some questions as we kind of talk about what we want to do next. So moving this back behind the dais to committee directives, I'm going to start with Representative Sherwood. And the question, because this is a subcommittee, we're not necessarily trying to sponsor bills or give that type of direction to LSO. But we need to talk about where to go next. We've got a couple of meetings, one October 14th, one October 28th. These are going to be held in the virtual world. And so we need to give direction to LSO as far as who to invite. And we have been given a couple of suggestions for an agenda. So I would ask my committee members to look at that. And if there is something on there that you particularly want to go into greater depth, please point that out. And then if there is something not on there that is on your mind that you would like us to delve into, please bring that to our attention, and then we'll see if we can't shuffle that into a couple of meetings. We do have the ability to go to an extra meeting if we need it. We asked for 5 and we've planned 4. So we gave ourselves a little bit of wiggle room. But Representative Sherwood.
Thank you, Mr. Chairman, and to the members of the Department of Health, thank you. This is a big lift to be able to take all of your services, all your passion, all your impact, and then shove it into a manageable format within a day. So thank you. Kudos for your work. I think the 3 things that are on my mind in the scope of just continuing to be educated and understanding your opportunities. I personally would love to revisit the exception requests. We know the supplemental budget didn't pass, but I want to hear from you guys on the things that you asked for in that the exceptional budget request, excuse me, which are still relevant, circumstances that have changed that make them not relevant. I'd just love a quick update on that. And if you're prepared to do a preview of what might be coming in the next budget request in 2026. So that's 1, those exception requests. 2, I'd love an educational update on what you're hearing around the HR1, that rural healthcare. So like you're doing the listening sessions, you're engaging communities. I think whatever you can share out with us would be great so that we can be more informed as well. And what that application might look like. And then 3, I think thematically, the workforce challenges. So you talked a lot today about the awareness of the shortage in positions. You've had some creative solutions, but I'm interested in understanding what else we could do to better situate ourselves to have those state employees versus contract labor moving forward. So those are my 3 things.
Thank you. I love it when people are organized. Yeah. One day, maybe I'll have more than one color highlight. I could be organized too.
Mr. Chairman.
Senator Larson,
I'm
please.
not that organized at all. I'm glad she brought all those points up because that's fantastic. I'm guessing that we're hitting all these topics again. Is that over these next two meetings? I like to ask Elizabeth.
Mr. Chairman, Senator Larson, that is to the discretion of Chairman Pendergraft on how you'd like to structure the budget or the next two meetings. We don't necessarily have to go through every single one again. That again is to your discretion.
So, Senator, looking at this list here, and I would pose the question back to you. Are there any of these items? We've heard from, I think, pretty much everything on here. Public health was covered pretty thoroughly. Healthcare financing, there's always questions there, and the facilities themselves. Are there any of those in particular that you would like to revisit, delve into, and then on the backs of the sheets, there are some other things. Yeah, there's the aging again.
Mr. Chairman, I guess with your indulgence, I think that that's a question I can't answer right now. I would like to maybe get back to you. And if there's some particular section I'm extra worried about or need more explanation, I would like to get back to you.
I actually tend to agree. Very hard right now to say, in a week or two, it might come from that, but we need to plan the next meeting. So I guess I should answer my own preliminary question first, which was, what are my priorities? I would really like to do some sort of an after action review. I would like to go back and look in detail at what was done in 2017 and what was done in 2021 and lessons learned from that. What worked, what didn't work. Do we, I have a tendency to want to follow the pattern done in 2017, but I don't want to fall into any pitfalls that may have been there and look at that. And again, we're not the ones that decide what we're going to cut or any of that. We've been asked by the committee to come here and make recommendations, educated as we can be in short notice. And so maybe the next meeting, the focus needs to be, let's revisit those cuts. Let's talk about the three things that Representative Sherwood brought forward. And I hate to say it, but maybe punt a little bit on the 28th and see, after we've had a chance to dig a little bit deeper and whatnot, do we want to bring some of these divisions back in for review? So any other comments on such? Yes, ma'am.
Thank you, Mr. Chairman. So to clarify, for the next meeting, which is October 14th, we will work on an agenda that looks at the 2017 budget reductions, the 2021 budget reductions, the 2025 supplemental that did not pass,
Correct.
the potentially rural health care transformation and the updates that you guys have been doing with your listening sessions around the state, a look at possibly the workforce challenges as well as any options that might be available. And we'll plan that for the next meeting. And then maybe at that point, we can revisit if there's any particular items you would like to look at for the 28th. Is that acceptable, sir?
I think we have a plan. And both times a plan came together, I loved it.
Mr. Chairman.
Yes, Senator.
I'm sure obviously we would like to hear what your budget might be in the future, but you've got to wait for the governor. But that's a tough one. We're kind of working on what ifs and what might be proposed, and it's tough.
Mr. Chairman, I was going to respond to that by saying, is that all for the next meeting? Seems a little light. But I will mention that my hearing with the governor for our budget request is scheduled for October 15th. So the day after your 14th meeting. So you're keeping me busy.
Isn't that a state holiday? October 15th is hunting season.
Not for Department of Health directors, apparently. I'll have to wait till another time. But to Senator Larson's point, I appreciate that discretion. We won't know final recommendations from the governor until, and I want to keep, not getting ahead of my skis there, since that doesn't come out until mid-November. There's just a lot of mechanics to consider when, setting the budget recommendations and balancing the state budget. So I don't want to overpromise and underdeliver there, but happy with any information that I have on the 14th to queue that up for the committee. But just a little bit of heads up, it might be lighter in detail than you would want, but more than happy, Representative Sherwood, to go over what the supplemental requests were, the relevance or anything that's transpired since. We talked about one today with the DD system that we tried to keep funded as much as we could with the failure of this last session's budget. But we can absolutely speak to those details, and it does dovetail in many areas with the Rural Health Transformation Fund. That is a very compressed timeline from the big, beautiful bill. We are gearing up to submit an application by November 5th, and we're more than happy to report out on the status of where we are with that. But the reason I bring that up is with some of the budget requests that, or at least topics that were part of the supplemental budget request, OB and maternity care, a variety of items, and some that were not, EMS, like we talked about this morning. There's potentially some opportunities with the funding that could be, and we won't know until late December, could be coming down the pike, that might warrant consideration by state policymakers, executive and legislative branch together. That could be a big opportunity for the state. It's fastly evolving, but we're more than happy to report out on that, both in its current form and its connection to budget requests. So happy to, I think the agenda sounds robust and interesting. So thank you, Mr. Chairman.
Thank you. I hope you can attend. Oh, I appreciate you people. The LSO staff over there, as always, have operated well. Do we need per diem sheets or something before you go? Yeah, so before you go, let's make sure we get those. I'm looking forward to the next meeting. I just had one comment about budgeting in general. This comes from my dear old Army years where I controlled no budget near as large as yours, but pretty substantial. And we had, basically what you did is you took last year's budget and then you added on whatever gravy you thought you could squeeze in. You usually asked for more than you knew you're going to get, and you come back to something else. And I know that there are members of the Appropriations Committee who would like to try to develop a little bit different thinking among the agencies, that we go back to a zero base. We start over each time and say, these are the most important things. This is what it's going to cost us. It's a little bit more work in a way to build it from there. But it may well be that there are just things, we do this, we ask for this because we always have. And I think we touched on a couple of those today, things that maybe aren't necessarily being used. Those are the things that we're going to be looking at as well. How effective is this? Could it be rolled in combined with something else? And trying to think outside the box, I guess, a little bit. So is it crowded? Oh, sorry, we are adjourned. Just kidding, sir. Senator Giroux, would you care to join us?
Thank you, Mr. Chairman. I've been listening all day, and very interesting stuff, and thanks for the opportunity. I just want to push back lightly on something you just said, Mr. Chairman. I just want to make sure I understand you were talking about your past career and what you used to do in your budget, but I want to make sure we don't leave anyone thinking that that's how we do it in the state of Wyoming, because it's not. And I would say to say that as a blanket statement across the way I just heard, and I'm sure I heard it wrong, so you can help correct me, but that one just kind of jumped out at me. All the rest of the day, I've been kind of listening along and following along with interest. But that one, I just want to make sure we were real clear on that. Thank you, Mr. Chairman.
Thank you for your comments, Senator. Well taken. Representative, do you have anything that you would like to add? You've been in and out today. Thank you. Any further comments from anybody? We are adjourned.